Our next speaker is Dr. Brian Helfand, and he's the chief of the Division of Urology for the North Shore University Health Systems. He's going to be doing a deep dive into BPH and showing really how does BPH work, what are the treatments that are available, and he's going to share about aquablation. He's had a lot of experience in this field. And Dr. Mark Moyad, who is our moderator, is going to have an extended Q&A session with him after his presentation. I hope you find this educational.
Thank you for joining us today. Today I'm going to be talking about advances in surgical therapies for benign prostatic hyperplasia, or BPH. I'm going to go through really what are we talking about when we talk about BPH, or an enlarged prostate, how we commonly evaluate it, and things to think about during that evaluation. What is the national and global burden of BPH? And then how do we actually address this surgically? And what are some of the newer therapies that are out there to address this common disease that impacts most men? And finally, I'm going to focus in on one of the newer therapies and highlight it, a therapy that is called aquablation. As a disclosure, I am on the board and a speaker for PROCEPT Biorobotics, who is the manufacturer of aquablation. And so to really start this talk, I want to make sure that everyone understands what we're really kind of referring to is that, as men age in particular, there's an increased frequency of lower urinary tract symptoms, meaning that men typically go to the bathroom a lot more frequently, they go urgently, they wake up in the middle of the night, their stream is often slower. And we always blame that, at least historically, on the prostate. But it turns out, just like everything else in this world, that urinary tract symptoms are not just a cause related to an enlarged prostate, or what we call benign prostatic hyperplasia, BPH, is all that same thing. In fact, there are many other causes that contribute to urinary symptoms, meaning you could have a scar tissue within the tube that a man pees out of. His bladder, which is kind of like a big motor, may just be underactive, or sometimes it's overactive. And sometimes many other disease states contribute to the development and overall severity of urinary tract symptoms, specifically diabetes, inflammatory bowel disease, arthritis, inflammation of the prostate, anxiety or depression, fluid intake, the amount of food types that men have, alcohol or caffeine, which are known irritants of the bladder, and other even more novel things like obstructive sleep apnea or sleep disturbance, and neurologic conditions, including Parkinson's disease and multiple sclerosis. So there are so many things that ultimately contribute. And it's our job as physicians to really figure out what is causing or contributing to urinary symptoms, and if it indeed is truly related to an enlarged prostate, or BPH. And just to support some of this, we as a research group, and many others as for that matter, have really looked into this kind of question of what are the causes of urinary tract symptoms. And we've looked at large databases. Specifically, there's a data set known as the UK Biobank. So this is a data set that was derived from Britain, and it tracks over 500,000 patients over time for about 15 years. And in that, some men develop BPH symptoms and others don't. And you can have the ability, because we have all of their medical histories for 15 years, to look at if there's associated, kind of diseases. And again, it's not surprising here that many other things contribute to the presence of urinary tract symptoms. That includes diabetes, sleep apnea, anxiety, depression, high blood pressure, coronary artery disease, increased body weight. There's so many things that are ultimately associated with the presence of urinary tract symptoms. And in past years, a lot of these urinary symptoms, we know that there are certain things that are even stronger predictors. So sleep disturbance, right? So I don't, we all make the association that, as we sleep, if we aren't good sleepers, we get up and then we have to go to the bathroom. But it turns out that association is even greater, and there are neurologic changes that happen when you're not a good sleeper. We and others looked many years ago at different data sets, and we found that the degree of urinary symptoms, as measured by what we call a urinary symptom questionnaire, in this case, it's the American Urologic Association Symptom Questionnaire. That the changes in sleep abilities, meaning that the worse sleep you have, the more likely you are going to get up overnight. We know that. But interestingly, the more trouble you have sleeping at night, it also impacts a man's daytime symptoms. So it actually tracks quite nicely in saying if you get up in the middle of the night, you're actually during the day more likely to go to the bathroom more frequently, more urgently, with a slower stream, etc. And so again, that's just an example of an associated disease process that we can address to help you control your urinary symptoms better. Of course, urinary symptoms are also associated with many other disease states, and certainly some of my collaborators who I work with at this institution are also interested in this subject. And we found that there is a strong association between the presence of inflammatory diseases and urinary symptoms. And when I'm talking about inflammatory diseases, I'm talking about things like Crohn's disease or ulcerative colitis or rheumatoid arthritis or psoriatic arthritis. These are very kind of common in the population. And the thought being that if you have an inflammatory disease, your immune response is kind of revved up, and that increased inflammation or revved up cycle in your system is also potentially associated with urinary symptoms. So again, we know we can look at large data sets and we can improve and show that yes, if you do have an inflammatory bowel disease or inflammatory process, you are significantly more likely to be diagnosed with urinary symptoms or an enlarged prostate over time. But interestingly, if you are treated with a certain medication, such as TNF alpha inhibitors, so the most common type that I think most people are familiar with are your Enbrel. So this is, again, a very common drug that is used for a lot of those diseases. And if you're treated with some of these drugs prior to, then you're actually less likely to be diagnosed with BPH or urinary symptoms. So it is one of those where we're studying this over time, and there are, kind of targets here and that we can prevent. And this is, kind of a follow-up study to this, showing that if you are treated with, Enbrel, a TNF alpha inhibitor, again, a very common medication that's used, if you're given mice these same type of drugs, they're less likely to have an enlarged prostate, and they don't, from a mice perspective, have the same kind of urinary symptoms. Based on this data, we do have an ongoing clinical trial that is now available, that we're actually giving a lot of these drugs prior to any type of intervention to see if this can ultimately improve prospectively urinary symptoms among men. So again, now that we know that there are a lot of other things that are associated with urinary symptoms, including a big prostate, how do we sort through this? Like, what should we do? And there's a lot of potential noise here, right? Everyone walks in the door. Most men have an enlarged prostate. Is that really the cause of their urinary symptoms? Or are there other things that we should be addressing? And that's really when we talk about now the evaluation and testing for patients, the current guidelines really show that you should gather the type of urinary symptoms that they have. You should use, standard questionnaires. The most common standard questionnaire that we use is the International Prostate Symptom Score, or IPSS. Again, this is used all of the time. It's the same as I just mentioned previously as the AUA symptom score, very, very similar. You can get other tests. You can have men come in the clinic and they can void or pee into a funnel to see how fast their urine goes. You can measure with an ultrasound how well men empty their bladder with what we call a post-void residual. You can look at, the contents of the urine. But again, with this, we always recommend that you should gather the other information. Do they have diabetes? Do they have sleep apnea or sleep disturbance? Do they have inflammatory bowel disease or inflammatory diseases? Because understanding that will help us address these other contributors to urinary symptoms, but that will also help treat men and their urinary symptoms and help identify really their predominant cause of their urinary symptoms. So again, this is now being included in a lot of the guidelines, but it's just highlighting an awareness that there are other things other than an enlarged prostate that contribute to the urinary symptoms. Again, one of the main things or questionnaires that we suggest, meaning the American Urologic Association or the main governing board of urology, is that when you evaluate patients who have urinary symptoms, use a questionnaire. Now, the questionnaire that I just recently highlighted is something known as the IPSS. IPIS would be the kind of funnier name of that, but it is really the International Prostate Symptom Score. No pun intended that we're really trying to quantify the severity of urinary symptoms among men. Now, this is a historic questionnaire, and I say historic, it hasn't been around forever, but certainly in 1992 is when it was developed and then subsequently validated in large cohorts, and it is a very good questionnaire. It asks all of the questions about how men empty their bladder, how they perceive the frequency of their urination is, or if they start and go or start and stop, if they have urgency, like the sensation that they have to go and they got to go now. If they have a weaker stream, or if they have to strain to void, or how many times a night do they actually get up to go to the washroom. And then in addition, it assesses how bothersome it is, meaning there's a quality of life question. If you had to live the rest of your life the way that your urination is today, how does that ultimately go on to impact you? And that helps us decide, if we really should be intervening, because again, this is not cancer. These type of urinary symptoms are quality of life. So if it's impacting a man's quality of life, then we have potential to intervene. And so this has been the standard questionnaire that has been used, basically what I would say forever. But even though it has been the standard and it is in every single guideline, there are major holes in it. There's no question about incontinence, meaning, hey, sometimes I go to the bathroom and I leak urine. That seems to be actually the most bothersome. That's not captured on this questionnaire. It doesn't say like, hey, after I pee that I have some dribbling, and there's some urine that leaks after I void. And there's certainly no questions about urinary pain, meaning, hey, there are some, conditions that are, kind of painful because I have inflammation of the prostate or something like that. That would be missed on these type of questionnaires. So there's been like a whole void, if you will, of space that we can better help patients if we could characterize them better. Meaning if our questionnaires were better and they really got to the main point and said, hey, you have sleep apnea, so you have a lot of urgency sensation and you leak because of it, that would help us potentially treat you better. And so with that, there has been an effort with a group that I'm also part of, known as the Learn Research Network. And this is a NIH, so a government-sponsored network. It's multi-institutional, so it includes North Shore, but there are many other institutions, including Michigan, including Iowa, including the NIH, including many of the other, kind of large institutions across our country. And we have over time worked together to develop a new and potentially better questionnaire that addresses a lot of the holes that the IPSS questionnaire doesn't currently take into consideration. And so with that, we developed a very patient user-friendly questionnaire known as the Learn, because that's the name of our group, Symptom Index 10, and the 10 meaning there are 10 questions that are asked. Again, this asks many of the same questions that the IPSS question asks, but it also includes urge incontinence, meaning I got that urgency and now I leak urine. It asks about stress incontinence. It asks about, dribbling urine, and it certainly asks about pain. And again, we've done a lot of work here and now have published with this and saying that when we've given this to patients, we actually believe that it's a little better. And again, it's the reason is that we're more completely able to understand what is most bothersome to patients, as well as what are the exact type of symptoms that are there. And as you can see here is that if we plot out the values, so if a man comes in and they fill out both the Learn SI10 questionnaire as well as the IPSS questionnaire, they track pretty well together, meaning that the general shape of this curve goes up at the same rate, meaning the values on one questionnaire are very similar. However, it's not a surprise that those men who typically have the worst urinary symptom scores, as measured by the IPSS, are also the ones that leak the most urine. So again, that also tells us that the questionnaire has a lot more value is because the reason why men are coming into clinic is they start leaking urine, and the old questionnaire didn't even ask about that. And now we have a better clue as to, kind of the reason why they come in. And again, when you look at bother, why guys actually came into the clinic, that bother is also captured by the Learn SI10 and also correlates with the IPSS. And it's no surprise here also that if you look at those kind of pink red dots here, that those are the men who have the worst urinary symptom bother because they are leaking urine. So again, just a novel tool that we have, a questionnaire that better helps us characterize why you're walking in the door and better helping with us. So now that we've gone through all this and we said, yes, we can identify factors that also, just like BPH, contribute to the presence of urinary symptoms, and we have better tools to better help us characterize or understand why men are having these problems and help us, kind of distinguish those men who have urinary symptoms from diabetes versus those men who have an enlarged prostate. What do we do about it? How can we better help treat men? And this is really kind of moving on to the next part of the talk, is to say, what is the real problem with an enlarged prostate or the presence of urinary symptoms related to BPH? Again, it's not cancer, but on the other hand, it is the most common reason why men present to seek urologic care. And when we look at the presence of an enlarged prostate and bothersome urinary symptoms related to that, we know that the presence of BPH increases with increasing age, meaning that we do know that over 85% of men who are 80 or greater in age years will have, moderate to severe urinary symptoms, bothersome symptoms there. Not all of them are treated, but certainly if you query them and you ask them, a lot of them have those urinary symptoms and potentially should be treated. And so again, we know that the global population, so the population of men around the world is increasing. And certainly in men greater than 9% of men over 65 in 2018 would present with urinary symptoms. And now over 17% of men greater than 65 are going to be seeking care in 2050. And again, when you look at the millions and millions of patients across the world, that burden of urinary symptoms, as shown by this, kind of blue line, is increasing over time, meaning that the burden of urinary symptoms or disease related to BPH is increasing. The problem with that is that that rate is actually increasing faster than any other urologic disease that we know of. Again, that strictly relates to the fact that we're living longer, throughout the world, and we're seeing, because of that longevity, an increased amount of urinary symptoms. And so with that, if you compare the burden related to an enlarged prostate, that is over threefold higher than those with prostate cancer or bladder cancer or kidney stones. So again, do we have the ability to really address it? And that's some of the problem here is that we really don't. The world estimates that, with this increasing demand, that, we just can't really keep up. And specifically, if you look at the yellow line here, that is a number of urologists. Those are the physician types that are treating men who have an enlarged prostate. And when you look at that, we can really cover about 1% of those men who come in this country with urinary symptoms. The demand of urinary symptoms is far greater than the actual workforce, the urologist number who are available to treat it. So it is truly an inequity there. And because of that, we have to be smart the way that we treat it. We have to be able to identify this quickly and be able to treat men very efficaciously so that it's not a, hey, maybe I'm going to get it right the first time. Maybe I'll try a few times to get it right. No, we don't simply have the number of physicians to get it wrong. So we really have to be able to meet that face of the increasing population because we know that the number of MDs isn't currently suffice. So as I just said, I don't know if the solution to the treatment is more clinicians. I don't think it's possible to so quickly train more urologists. Certainly, we can talk about more prevention, risk stratification, education. We know, as an example, if you can control the amount of obesity, or you can better control sugar control in diabetics, or you can help or prevent sleep apnea, then potentially you can help with some of that problem overall. I don't know how many new drugs are coming into play. We haven't seen a lot of new drugs recently, but are there more cost-effective treatments? And that's really kind of some of what I'm going to get into with this talk is to say, if we can do a treatment and we can get it right the first time, and so therefore I don't have to follow you or expect that you're going to have a recurrence of those urinary symptoms or a recurrence of an enlarged prostate, then potentially we can start addressing some of this. And so this gets into what is the efficacy and durability of a lot of the things out there right now. So I didn't yet talk about it, but a lot of the current guidelines always tell men that we should start off when a man comes in with urinary symptoms. Some of our first line treatments we should consider as physicians offering those patients medications, pharmaceutical drugs that can impact their urinary symptoms in positive ways. And there are several classes of drugs, and we'll talk about some of them. These are alpha adrenergic antagonists. These are drugs like tamsulosin, formerly known as Flomax, or Rapaflo, Silodosin, etc. And so these are good drugs, but in general, if you started off with an IPSS, that score of 25, a higher score indicates that it's more severe urinary symptoms, and you provide someone a drug, you're only going to see about a 7 to 10 point improvement in their urinary symptoms, saying, hey, you're going to feel better. We can give you this drug. You're going to have to take that drug every single day, and you're going to get, some moderate relief of your urinary symptoms. That sounds great, but we can do better. We can definitely do better. And so within the past 5 to 10 years, we've come up with some other type of therapies. These are generally less invasive type therapies that use a clip, or they use they burn a little of the prostate. These are non-resective type of procedures, and they give you a little bit more relief, meaning that you'll get a 10 to 12 point improvement in your urinary symptoms. So, hey, the cool part about a lot of those is that you don't need to be on a medication for the rest of your life. And they do better than a lot of the drug therapies, but they don't totally get you there. And there is some question. What we'll talk about is for non-resective type procedures, these are generally, again, the more minimally invasive type, the durability, their ability to act over time may be in some question. Now, again, if you're treating urinary symptoms and you say, hey, I know these urinary symptoms are because of an enlarged prostate or BPH, then I can also go in and shave part of your prostate down, something we call a resective procedure. These have been the most historic type of procedures used. We know that they are very, very durable. And when we do resective procedures, they have the largest improvement in urinary symptoms. So you can expect that, again, you can expect about a 15 to 20 point improvement if you do a resective procedure. And again, the advantage there is that they tend to be very durable. So again, I think understanding where we are in the current type of therapies we can offer patients and manage patients' expectations and say, hey, I can get you through a little bit with a drug, knowing that there's more that we can do. I can do a little bit more, a non-resective kind of minimally invasive therapy and get you a slightly better type of improvement. Or alternatively, I can go for the roto-rooter, shave your prostate down from the inside, those type of procedures, and get the maximal improvement there. And so to go through those a little bit more individually is, what about medications? Medications, again, are always considered the start of where we begin. Someone comes into your office, they say, hey, I'm bothered by urinary symptoms. I have a weaker stream. I'm getting up in the middle of the night. The kind of gut reaction is, I'm going to give you a drug called tamsulosin. The other name that I historically said was Flomax. And we're going to see, how you do. There are other, kind of forms of therapy there that you can give a 5-alpha reductase inhibitor. These are another class of medication that help shrink your prostate down. Or you can give them together and get more maximal therapy. The problem with it is if you look at the overall adherence, meaning if you give any patient a medication, whether it's an alpha adrenergic antagonist like Flomax, or whether it's a 5-alpha reductase inhibitor, their overall compliance, the adherence to taking those medications is low. And this, study of, over 200,000 men that were given medications for their enlarged prostate, only 30% of them remained on those medications at 1 year, meaning 70% said, hey, I don't like the way that this is making me feel because of side effects. I don't like that I have to take a medicine every day. Or maybe they said, you know what, I just am not really getting any different relief or benefit from this drug. I'm going to stop it. And again, when you look at this and you look at the long-term use of this, it's just very, very low. And so again, that tells us that maybe medicines are not the answer. And as I just said, is if you're going to treat a man with a therapy, you want to see its efficacy. And again, compared to any surgical therapy, medications do improve your urinary symptoms. That's not in question and has been shown. It's just in general not to the same degree. We're not going to relieve your symptoms to the same degree that we can if we would do surgery. And again, what have a lot of the studies shown us is that no medication is totally benign, and there are side effects there. Kind of a lot of these medicines, whether it's an alpha adrenergic antagonist, so in this case it's doxazosin, or a 5-alpha reductase inhibitor known as finasteride, is the kind of new onset of erectile dysfunction or retrograde ejaculation, meaning that when you orgasm, that you may still have no problem having an erection, but the amount of fluid that comes out is significantly decreased or absent, that's high. It is present in at least 2/3 or more of patients that they will have, these kind of side effects. And again, a lot of these type of side effects are so bothersome that lead to men stopping these medications. And when you really look at this, is that, their overall sexual drive, their ejaculatory function, and their, kind of sexual function is really compromised when you're taking these medicines. So it's one of those where we used to, as urologists, say, you know what, it's fine. We don't have to pay so much attention. It's more important that we focus in on your urinary symptoms. But again, it's no surprise that it has really become called to our attention to say men aren't taking these medicines because they're so concerned over their sexual and erectile function, and they should not be having to choose between, hey, I want to pee, so I should, I should have compromise on my overall satisfaction with my sexual activity. So again, we have all of these different things, right? Is that when we look at this, we have a spectrum here. We can give men medications, and that, well, again, may not be as efficacious in terms of urinary symptoms. You got to take something the rest of your life. They may compromise your sexual function, or they could, have other side effects. On the other hand, there's slightly minimally invasive type therapies that are either baskets or clips or kind of burns of the prostate that we can do even in the office, that again increase the ability to urinate better, but they may not be as durable. And then on the other hand is you start getting, once we get to the right side here, we get more aggressive in terms of how we're getting rid or shaving down your prostate. And so we can do things like a TURP or transurethral resection of the prostate. And that's where we literally go in with small cameras and we use a cautery device and shave the prostate down. This is one of those that historically was really referred to as the Roto-Rooter, because it went in and shaved that down in the same kind of fashion. It is still considered in today's modern era the gold standard by which things should be compared against, because it has been done for so long and we have so much data that supports its efficacy. But there have been modern versions of this. So you can do a laser procedure to shave your prostate down. You can use a green light laser, which we call photovaporization, or we can use a holmium laser to either ablate that tissue or actually enucleate, carve out that tissue, things that we call HOLEP. There are different things that we'll call aquablation, and on the other hand is that there's even more aggressive surgeries where we can, carve up the entire inside of that prostate using a robot these days, or or using our finger still, and so these are really on the more invasive side, because on the right hand side here is that we got to make incisions into the belly and see the prostate on the inside. So again, there's a whole spectrum of things that we can do. And the more aggressive you are, meaning the more invasive you are, historically, the more likely you were going to have side effects, meaning that you were going to have sexual dysfunction. You could leak urine, but they were in general considered more durable. And on the other hand is if you do kind of a less invasive type procedure, you may not have the same degree of improvement in urinary symptoms, but you don't have that to worry that you're going to have the sexual dysfunction or leak urine, etc. So there's a kind of a balance here. And the question is that, is it fair to make patients make this choice, right? Like if you want the ability to urinate better, that you should have to compromise or give up your sexual function? Or we have to say, do you want a durable procedure or not a durable? Do you want to do this many times? And again, understanding the global burden of disease, like should we offer patients that choice to say, well, we should give you something that only gets you 1 or 2 years of benefit, but in 2 or 3 years, you're going to need another treatment. So there's all these type of questions, and a lot of them are, kind of ethical, but really should be in the hands of the patient in a shared decision making to say, well, do you want a medication? Do you want a minimally invasive procedure? Or do you want a more maximally invasive procedure? Are we the ones choosing, or should it be the patient? So yeah, I'm going to kind of switch gears a little bit here and now talk about, kind of how we are evolving and what is the current landscape of surgical interventions for the treatment of an enlarged prostate. Again, as I brought up, is that the Roto-Rooter, what we call the TURP, or the transurethral resection of the prostate, has really always been considered to be the gold standard. That is, again, we do it in the operating room. The patient is asleep, and while they're asleep, we take a camera, go in through the penis into the prostate. We can see the prostate on the inside, and then we use a cautery device and we shave the prostate down, which basically opens up that prostate channel, relieves that blockage, right? Because normal anatomy is that you have a bladder. The bladder then sends urine through the prostate and then out through the tube through the penis. And by shaving that prostate down, it basically gets rid of that obstruction, that tissue growth because of that enlarged prostate. And when you look at the current frequency by which various procedures are being done in this country, you can see that TURP, which is shown in blue here, is the major procedure that continues to be done throughout this country. Certainly, laser surgeries with that green light, which is ironically shown in yellow here. Urolift, which are clips that kind of pin open the prostate. Those are shown in green here. The microwave technology, which historically was used, it's actually shown that it wasn't efficacious. But again, a more minimally invasive procedure has really kind of dropped off the map there. And then there are other players like Resume and HoLEP, which I'll talk about, which are kind of have become more into the scene here. But again, looking at and understanding what are the current available techniques to surgically shave or open up that prostate channel, we have a lot of choices here. We have a lot of choices here, but the gold standard TURP continues to be the most utilized here. And so how do things, kind of compare and what are some of the technologies out there? Let's just talk about stuff. So the prostatic urolift or the urolift, as it's kind of known as short, are technologies more minimally invasive. They don't resect tissue, right? So what they do is that they are placed, these are clips that go in into the patient's prostate, which basically pin it open. So the urolift is done. It can be done in an office setting. It can be done in an operating room or a surgical center. The overall time it takes is about 5 to 10 minutes to do. If a patient is done in the office and the patient is awake, ultimately the urologist will give a numbing or nerve block so that it's not as stimulating or painful of a procedure. They then take a camera, they go through the penis, see the prostate tissue on the inside, they identify where it's kind of pooching out or blocking the prostate channel. And then they take these clips, which are shown in the diagram here, and they pin them into the prostate. They clip it open to enlarge that channel. So at the end of this, again, that there's an opening there that the bladder can squeeze the urine easier through. And again, I give this a lot of props because it is something that really, I think, caused our attention to the importance not only of urinary symptoms, but also the importance of preservation of sexual function. And as you can see here, is that, these are a 5-year data set. So these are men who underwent the urolift. And then they followed them over time here. And as you can see here is that there was a significant improvement. So the IPSS score dropped from 25 down to about 12 here, about half did, and followed men over time. And in general, men did very well. And if you look here, the quality of life, patients were bothered. They underwent a urolift, and they stopped having the same degree of bother from their urinary symptoms. This sounds excellent. But over time, there was about a 14% of men in this 5-year trial that needed a retreatment, saying, hey, we got you some initial improvement, but within a short time period, whether it's 12 months, 24 months, there are, men who needed retreatment, and 14% of those men required an additional surgery. So 4% needed, wanted another clip, another urolift placed. And 9% said, you know what, I'm done with this. I want a more traditional proven procedure. So they went back to the TURP or the green light. And when you look at this in the real world, is that every year that a patient has, after they underwent a urolift, about 6% of men are treated again, meaning saying, hey, the urolift was great for a little bit, but or maybe it didn't work at all. So I need some other type of treatment to really improve my urinary symptoms. And again, that somewhat is a problem of saying, hey, we can get you there. We're going to do better than medications, but it may not be that durable. Again, that's really important to understand here is saying, hey, with the large burden that we may intentionally use something like the Urolift as a short solution. On the other hand, is it may not get men to exactly where we need to be. So again, counseling patients to say that Urolift is a viable option these days, but it just may not take us across that urinary symptom goal that individual patients may have. The other thing that I didn't present here is that Urolift does preserve all aspects of sexual function, meaning that there is no retrograde ejaculation that occurs after Urolift. So again, from a side effect profile, because it's just clips and it's not resecting any tissue, these men do great from sexually. There is another therapy called Resume. Resume is again, a more minimally invasive type procedure. What it does is it again uses a camera, evaluates where the prostate tissue is, and then injects. So there's kind of fang-like prongs that come out, and then will inject steam into the prostate. That steam energy, it heats up that tissue and causes that tissue to die or slough. And then those patients, that prostate sloughing tissue, which is now dead after the Resume, will eventually open up, become remodeled, and then the patients will not have those urinary symptoms over time. And again, here is a 5-year trial outcome. So looking at men who have undergone Resume and then been followed up to 5 years. And again, we see the same significant improvement in urinary symptoms. So these men had significant improvements in their bothersome urinary symptoms. Their overall flow rates, how fast they could pee or void, also significantly improved. In their 5-year trial data, about 4% of them were surgically retreated with other therapies, including a TERP or a green light, really within the first 2 years. So again, it's one of those where it is minimally invasive. It's easy to do. And again, it takes about 5 minutes to do in the office. It's just one of those that the durability and effectiveness may not be what a lot of men are choosing to do. Meaning if you try to do, hey, my goal is that I want a one and done procedure. I want to reset the clock to a time when I was 20 where I could really pee with strength and not think about it. This may not be the type of therapy that you're really going for. And again, when you look at the real world, which is separate than any type of study, is these rates of retreatment are often higher. And about 5% of men are retreated on an annual basis after they undergo Resume. So again, it's not that it's wrong to do. It's certainly a viable surgical, minimally invasive therapy. Again, very easy to do, but again, understanding that it may not get you the same type of improving results as a TERP, the gold standard would get you, and it may not be as durable as some of the other procedures. So moving on, as I said, there are other cool things that you can do with lasers. So there is a technology called HOLEP, or holmium laser enucleation of the prostate. This is where a patient is done. Again, it's in an operating room setting, so you cannot do this in the office. You either have to do it in the hospital operating room or in a surgery center where you would be asleep. While you're asleep, the urologist will take a camera, go in, see the prostate, and then use a laser and in big chunks, if you will, of that prostate, carve out all of the inside of that prostate. So I always say that if a prostate is like an orange, this ability is you're going to get rid of all of the juicy part of the orange and leave the peel. Now that juicy part of the orange is then pushed into the bladder, and there's a separate device known as a morcellator that will take the juicy part of the orange and chop it up into little bits, which are then sucked out at the end of the case. This in itself is a very effective procedure because you're getting rid of all of the adenoma, all of the juicy part of the orange, so you're maximally opened up. And again, that should be, kind of a cool way. There's no incisions, and patients do really well. However, we have to understand that this HoLEP technology utilizes a laser, and lasers can be problematic because they impart some of that energy to the residual, the peel of that orange. So remember, because we're only taking out the juicy part, we leave that peel, and that peel stays in the patient. And the problem with that is that because it absorbs that energy, it is associated with a lot, or at least temporarily, a lot of urinary symptoms, meaning, hey, afterwards, for several months, if not a year afterwards, that men can have that experience that they have a lot of urgency. I got to go to the bathroom. I got to go now. And many of those men may leak urine. And about 30% of men after this procedure will temporarily have what we call stress incontinence, meaning if they cough or they sneeze, they may have some degree of urinary leakage. Again, most of those patients, about 98% of them, will recover their stress incontinence. But again, it's important to be aware that these may be temporary, or in very rare circumstances, permanent side effects that you can have from this procedure. But from an overall urinary symptom standpoint, it is certainly a significant improvement over a lot of the medications, and certainly over most of the more minimally invasive procedures like the Resume or the UroLift, which we just talked previously about. The interesting thing is, if you compare HoLEP to the gold standard of TURP, where we use a cautery device versus a laser to shave your prostate down, that certainly the quality of life is actually in favor of TURP. And again, the reason why is that the cautery device doesn't usually impart a lot of those irritative urinary symptoms, the urgency or the incontinence following the TURP that you do see for the HoLEP. So again, in general, TURP is a little bit easier of a recovery for many men. But on the other hand, there are many advantages that it can be done on anticoagulation, meaning on blood thinners. It's done in a truly a minimally invasive fashion. And the durability of HoLEP, I don't think can be argued with, because if you're looking at 5-10 year studies, because you are getting rid of such a large portion of the prostate, that you really don't have those type of retreatment rates that I previously just showed you for UroLift or Resume. But if you look at the actual growth or use of HoLEP across this country, it really hasn't increased in the numbers over the past decade. And the reason being is that it's a long procedure to do. It's not easy to do. There are, only a certain number of us urologists who are really trained to do it and do it well. And as such, it's not really meant for the average urologist across this country, in my opinion, because of that. There is a steep learning curve. I mean, it's been estimated that urologists will require about 250 cases or more to become competent in it. And so the question is that really a practical procedure to do across this country when we understand the global burden of our population that continues to increase on an everyday basis? I would argue that it's not necessarily going to solve our problem here. And so again, when we look here and things are changing, that we are seeing a increase in the number of minimally invasive procedures over time, including the prostatic urethral lift shown in blue. We are seeing an increase in water vapor therapy, the resume. We are overall seeing a decrease in TERP. And so what is this ultimately being replaced by? Where are we going to this? What is going to be kind of next on slate here? And so I'm going to kind of really quickly brush over some of the newer concepts here before I really focus in on aquablation here. But there is a technology called Optilume. BPH, which is a balloon that basically is blown up intentionally in the prostate. Again, done in the operating room. So while it's blown up, the patient doesn't really feel this. And it's blown up, so it actually stretches out the prostate so much that it also causes a tear on the top part of the prostate. And by doing that, after it stretches it out and causes that tear, it releases a chemotherapy, a drug called paclitaxel, which inhibits the kind of normal healing. So as you stretch it out, you don't want it to reform. So this drug is believed that it helps reform that. And when you do this type of stretching, the Optilume, that there is a significant improvement in urinary symptoms, and flow rates, and the amount of men that hold. So it appears to be an effective treatment. I think the long-term outcomes will show, but when we look at, kind of a double-blinded study where guys were either randomized to a sham, so nothing really happened, or an Optilume, is that there is a significant and sustained, at least to 1 year, if not, kind of 2-year data that is showing that the improvement in urinary symptoms is there. And again, with all of these type of more minimally invasive treatments, there really is no change in sexual or erectile dysfunction. So again, that after the procedure is done, when men orgasm, the amount of fluid that comes out is preserved after these more minimally invasive. I did not mention that for HoLEP, it's about 100% of the time, that laser enucleation procedure, that when men orgasm afterwards, they have retrograde ejaculation, meaning that there is no fluid that comes out. There is another therapy that patients may hear about called prostate artery embolization. So this is again under the class of more minimally invasive. It's based on the concept that the prostate is fed by arteries, blood supply, and that if you go and occlude that blood supply specifically to just the patient, that prostate tissue will die because there's no blood supply to it, and that men will ultimately do better. This is considered one of the more controversial types of therapies that's currently out there, because it's been tested in somewhat controversial ways. On the other hand, there has been crossover or randomization studies which may show its effectiveness. Again, that we don't have the long-term data on this, but men who do undergo prostate artery embolization do have an improvement in urinary symptoms and quality of life. But we do have to understand and recognize that the results may be variable, meaning that if you have a very large prostate, that you may not be amenable to this. If the blood supply to the prostate isn't ideal, meaning that there are many, many different branches that you would have to occlude to get this, you may not be ideal. And it is also user dependent, meaning that the radiologist, so it's not the urologist who generally do it, it's what we call interventional radiologists, who do this with machines and under X-ray vision, that they if they have a lot of experience, that it could be better. But again, these are all different factors that may be difficult to control and may influence the outcome. I bring this up because, again, it is one of those that is included in our urology guidelines, but I currently say that it shouldn't be considered the standard or for most patients based on that. But again, when you look at the data, that there is an improvement in urinary symptoms, we still don't know the longevity, how durable this will be over time. There's also a therapy called iTind. An iTind is a newer therapy. It again can be done in the office. It can be done in the operating room. It literally takes about 5 minutes to do the whole thing. You take a camera, you go in, you see the obstruction from the prostate, and instead of blowing up a balloon, you actually leave a nitinol basket, a wire basket in the prostate, which over time kind of stretches out that prostate, makes some incisions over time into that prostate so that it basically springs it open. And again, this is a device that has been studied in the same regard. We don't know its overall durability. We do know that it's more ideal in certain size or shape prostates. If you have a part of your prostate that grows into your bladder, something we call a median lobe, you are not a good candidate for something like iTind. The actual nitinol basket stays in for a total of 5 days before it's removed in the office. Again, it's nice because you can easily place it, but again, we just don't know the durability because it's not removing or resecting any tissue. And again, when you look at the overall improvement, it does improve urinary symptoms. It does improve quality of life. It is, considered an option for many men with BPH, but it is one of those where it may answer some questions because of the fact that that we can do it and it's so quick to do that we can treat a large number of patients very quickly. I don't know if it's ultimately going to have the same durability, but that may not be the goal of this type of procedure. There are other forms of treatment that are now coming into the space. There are different types of nitinol baskets. One of them is ZenFlow. ZenFlow has just seen its several year outcomes data. Again, this is a more permanent type of basket that sits in the prostate. You can take it out at any time, but it basically serves as a opening, a little pipe, if you will, that keeps that prostate open, that allows that channel to be unblocked. Again, not for very large prostates, but certainly for certain size and shape prostates, this may offer patients a more permanent type of solution to help with their urinary symptoms. Again, just like every other technology I've shown, does improve urinary symptoms as well as quality of life. And there are so many new players in this kind of nitinol basket space. I don't have time to go through all of these, but all of these have the same type of potential to quickly improve urinary symptoms. They can be easily placed in the office or in the operating room, depending on patient preference. And again, their overall use may be limited to certain sizes and shapes, but they are certainly being investigated as patients there. So with this, I really wanted to focus in on one of my, kind of new favorite technologies. This is really highlighting aquablation. Aquablation has now been around for over 7 years when it first received its FDA clearance and approval. And again, the beauty of this is that it really, compared to almost every other technology out there, has the ability to address any size or shape prostate. I really didn't get into this, but a lot of the technologies out there, whether if you have too big of a prostate, or if you have a median lobe or a certain funny shaped prostate, you can't do those technologies because they are just not designed specifically to address it, or they're going to fail because you're leaving that tissue behind. And when you look at this, Aquablation really said, hey, we can have that ability to get rid of a lot of the tissue there. So it is a resective technology. It uses a water jet, a water pick, a high pressure power washer to resect that tissue. And in that way, the results should be very durable. It is done, and I'll explain it on the next slide, under ultrasound imaging in real time. So you can actually watch the technology in action. You can watch that water pick get rid of that tissue. But that real-time visualization allows you to avoid critical structures. Those are the ejaculatory ducts. Those are the things that we value for anterograde sexual function, for normal sexual function, so that after an aquablation procedure, most men, 90% or more, will actually retain their fluid when they orgasm. And again, that's very different than historic, kind of procedures, right? Because you have, on one hand, you have these non-resective procedures. They may not be very durable. They certainly can handle large prostates, but they always preserve their sexual function. On the other hand, historically, when we had TERP or when we did a HOLEP, we got rid of their sexual function. We had maximal durable symptom relief. So was it really fair to make men choose? And Aquablation came into this space and said, hey, we have the ability, we can offer the benefits of a resective procedure, maximum urinary symptom improvement, but we can also preserve your sexual function. So this is really how it works. Again, the aquablation is done in the operating room. So men are asleep. They're not in any pain. They do not feel this procedure. While men are asleep, what we do is that we insert a ultrasound imaging probe. So we can in real time image that prostate tissue, see it on an ultrasound, and then we can make a plan based on that ultrasound. That is why you can do any size or shape prostate, because it can really handle anything. And you're designing that plan, you're personalizing that plan for any size or shape. Afterwards, you take a camera, you go through the penis, you see again the prostate on the inside. And then, based on that, there's a water jet that then talks to the plan that you just created based on the ultrasound images. And that the water jet then precisely gets rid of all of that tissue, and then you're done. The procedure itself takes about 35 minutes in total, meaning that by the time you go into the operating room to the time you leave the operating room, that's about 35 minutes. Your plan includes those critical structures. So again, I said is that if you look at the yellow diagram here, it preserves your ejaculatory ducts. It preserves those things that we value the most. It preserves the bladder neck shown in blue, that entrance to the prostate there. So it is really designed in a very fancy way. And if my prostate looks one way and someone else's look another way, we cater that program to every man's prostate size and shape. So it's truly personalized. And again, I said is that it has that ability to identify that critical anatomy. So it gets rid of the obstructing, what we call lateral lobes of the prostate that are pushing in. It preserves that bladder neck, which helps contribute to the preservation of that sexual function. If you have a median lobe, which is shown in number 1 here, and it's protruding into the prostate, it will take care of that water jet, will design it and get rid of that median lobe tissue. Again, it also preserves the veru. That's where the ejaculatory ducts come in. That means that you aren't leaking urine after the procedure. You don't, if you cough or you sneeze, we don't have to worry about that. In addition, because it's using a water jet, we're also not only precise in how it goes, but we don't irritate that residual rind of the orange, so to say, because water is not irritating like laser energy. And again, it doesn't make a difference the size or shape, meaning if we did a TERP, that classic procedure that we do, or the HOLEP, that holmium laser enucleation, we do know that the larger your prostate, the longer the surgeon is going to have to be in the operating room and work on you. Because again, the more prostate tissue is there, the more work that was going to have to be done there. Aquablation is virtually agnostic to prostate size, because if you have a small prostate or you have a large prostate, the difference that you're talking is just several minutes that a patient would have to do. So this is data that was captured by the randomized trial. So Aquablation in their Water 1 study, so that involves water, so they cleverly came up with a name, the Water 1 trial, that compared Aquablation to the gold standard. There is no, which is TERP. There is no other technology that right out of the gate went against the gold standard. And they did this, and what they showed is that the TERP, which is shown in orange here, the larger your prostate, the longer that surgeon was going to be in the operating room. But if you look at the blue line, it doesn't make a difference which is the aquablation line. It didn't make a difference if you had a small 30-gram prostate or you had a large 150-gram prostate. You were essentially in the operating room for around the same amount of time. So again, that makes it kind of agnostic. But when you start thinking about the global burden, you start questioning and say, hey, I can be in and out of the operating room. I can do many of these procedures and around the same time. That may help us treat patients. And again, when you look at the results that are created, it's so impressive. There's a huge defect here. So if you look at the top bar here, you can see here that the white prostate tissue, the lateral lobes are kissing or they're pressing in. The aquablation is then performed, and you can see that there's a large, big defect that's created here. This defect is sustained for many, many years. Again, we've looked back and now many have had this over 7 years ago, and this concentric round hole that we intentionally created with the water jet is maintained for many, many years afterwards. And again, just so you don't think, hey, Brian Helfand is just making this all up. This is actually, all of this is based on data that has been accumulated in the literature. Meaning that, again, we talked about the Water 1 study. We talk about the Water 2 study that was larger prostates. There has been real world data. This has now been utilized in over 50,000 patients across the world. And when you look at that, it has significant improvements in urinary symptoms. Again, the Water 1 went against TERP out of the gate. And in that study, in a subset of men, there was significantly improved urinary symptoms compared to the gold standard of TERP. There was a lower risk of complications. Again, 90% of men maintain their ejaculatory function, their sexual function after this treatment. And very few retreatments are performed. When you look now, we generally quote that the retreatment rate is about 0.2 to 0.7% of patients a year. Again, compared to 4 to 7% of men who've undergone either a Resume or a UroLift. So again, we're talking about a very durable, effective type of procedure. Again, I am not going to go through all of the data here, but again, just supporting the fact that it is really an efficacious procedure. It has, because of its efficacy, been included in the American Urologic Association, our Urologic Association guidelines, the European guidelines, the Canadian guidelines, the British guidelines, again, considered to be a very effective treatment strategy. Again, when you look at the results, now just focus in on the blue bars here. After 5 years, it's associated with a 15-point improvement. That's a 69 percent change from their baseline to improvement. Huge improvement in their urinary symptoms. Huge improvement in quality of life. Huge improvement in uroflow. How fast that urine is flowing through. Almost no ejaculatory dysfunction. 7%. Again, TERP can be up to 80% of men who have sexual or ejaculatory dysfunction. No risk of erectile dysfunction, and really no risk of leaking urine. Again, going through this, if you look at their overall urinary symptoms, huge and significantly sustained improvement in urinary symptoms in any of the studies that were performed. Huge improvement in the flow, how fast that urine is going. They're not obstructed. And again, if you look at even the large studies of studies in aquablation in large prostates, 150 grams or more, you see a similar improvement there. When I've looked at my experience with aquablation, it equally is reflective of that literature. So I've now done many hundreds of these cases. I have analyzed the first 300 of these cases done. Again, I've treated prostate volumes as low as 20 grams and as big as 535 grams. So huge, huge monster prostates here. The average size that I treat is about 108 grams. diagram. Again, that's a very large prostate. About half of them have part of their prostate that it grows into the bladder, that median lobe. And about a third of the patients that I treat present with an inability to pee before the procedure. And almost every single one of them, 99+%, are able to pee after that procedure with extreme ease and an improvement in quality of life. Again, when you look at the overall improvement in urinary symptoms, again, all of these men significantly improve their urinary symptoms, their post-void residual. I'm not showing here, but they have an increase and significant sustained increase in urine flow. About 90 to 92% of them have anterograde, ejaculatory function. But the interesting thing is that yes, I do see that I am in the operating room when I start getting into monster prostate sizes, slightly longer. But the longest that I typically am in the operating room for any of these procedures is an hour or less. And the average amount of time is about 37 minutes. So it is one of those where this is very, very efficacious. No one would dream that we can take care of such large prostates, 150 grams or more, in under an hour. There is no other technology that is equipped to handle such size. So again, very, very efficacious. And none of these men really need retreatment. And certainly their follow-up period. Again, when we look at even case number, this also shows that how easy it is to use for urologists is, if I look at the first 50 cases that I did, shown here, or if I look at, kind of my 250th to 300th case, the average amount of time I'm in the operating room has improved a little bit. We went from 47 minutes down to 42 minutes. So it is one of those where there's not much of a learning curve here. And again, that's really, really important when we start talking about offering a technology across this country, because you want many, many patients to get it. You don't want a barrier to say, hey, that urologist needs to learn so many cases before they can actually offer it. So very, very advantageous there. And again, when you look at the overall size of the prostate, it doesn't really make a difference of how big your prostate is. We're kind of in and out of the room in a very similar amount of time. And so is Aquablation the answer? If we look at the largest prostate in Chicago, which I would argue is the Bean structure, which is in downtown Chicago, it may be the answer for many, many patients. There are very few contraindications that I can come up with, and a very, very successful procedure. But again, a lot of this decision comes down to shared decision making. So if you're a patient and you're sitting and you're saying, hey, what would be the best therapy for me based on the bother my urinary symptoms, based on the cause of my urinary symptoms, based on the fact that I want to have no pain and I want a one and done procedure, etc. These are the type of conversations that you can have with your patients. And there are actually now, and this is not surprising, there are applications that you can do on the computer to help you even prepare for this. Canada, with some of those urologists up there, came up with a shared decision-making tool to best help understand which may be that most appropriate surgical therapy for you. Again, I think that this initial application is primitive. On the other hand, I think I applaud them because they came up with this, and I think that we'll only start seeing that this type of application and shared decision making will only become more and more. So really kind of here is that, in summary, is that BPH is an increasingly expensive and it's a common problem. We don't really have any new medication that's been offered in the past 30 years. And as I showed you, is the compliance is overall poor. But there are many alternatives if you would ultimately say, hey, I'm bothered enough that I want to undergo surgery from this. The surgeries are effective. They are way more effective than medications. On the other hand is that you have to need to help choose if you want a durable procedure or if you want something less durable. And so understanding that there are these new technologies out there, but we need to understand their long-term results and what our goals of treatment are. There is a procedure, aquablation, that may ultimately be a one-size-fits-all approach to patients because it can handle any size or shape. It isn't associated with a lot of the historic problems that we saw with sexual dysfunction. But I think the key here will ultimately be shared decision making. And with that, thank you so much for your time, and certainly always excited to talk about treatments for the prostate.
I mean, I should stand for you. Maybe I will. Just a second. It was that good. You know, I know you and I have been friends, but that was even better than your genetics talk that you did not that long ago. I know you can't compare them. It's like comparing an apple to orange, but it was really comprehensive. It was really awesome. And I appreciate that. Thank you very much.
It was my pleasure. It was fun. There's a
You,
lot
you
out there. That's the problem.
Well, you did something that not a lot of people often do, because when you and I talked earlier, we said, I want a comprehensive talk. This is a massive subject, but then also talk about what you do at the end. And you talked mostly about the rest of the competition, which is unheard of. So kudos to you, my man. Not only are you looking sharp and your skin right now is smooth and sublime, but overall, this is like, it's a dream comprehensive talk. So thank you. I just want to remind the audience that last time he was here, he talked about genetics. I did ask him the key question: if Michigan played Northwestern in football 100 times, how many times would Michigan win? And he correctly answered that Michigan would win every single time. So we got that out of the way. And for those of you who weren't there last time I talked to him, I thought the name of North Shore Urology was the name of a urology group in Hawaii, and you cleared up that you're not. You're in the Chicago area. So that was another one of my favorite jokes. I don't know how much you enjoyed that. And then I had a couple more, but instead I'm going to ask you one genetics question in prostate cancer, if you don't mind, because let me remind the audience, if you haven't seen Dr. Helfand's talk on genetics that he did essentially not that long ago, it was comprehensive. It was unbelievable. And I thought at the end of the talk, I kind of wish I would have asked him the most obvious question of all. And I wondered if he had a comment on that. And I don't think a lot of people realize this, but this is what comes up a lot. And I've seen it in some of your publications. You know, prostate cancer is one of the most heritable cancers of all the common cancers. So that people don't realize how strong the genetic component is to prostate cancer. And I think you helped get that across in your first talk. I don't know if you have anything else to add to that, but you know, it really kind of, every time I read that, Brian, it kind of blows me away that it's so heritable.
It's really kind of the prototype, the example of cancers, and understanding how it can be passed from generation to generation. But what's even cooler is that I'm not just so limited to the cancer, the genetics of prostate cancer, but we also look at the genetics of BPH, and BPH is even more heritable than prostate cancer, if you believe.
What?
That's right.
First comment on your talk, like genetics and family history with BPH. You're saying it's more heritable. So if you've got a history of BPH in the family, you best tell your doctor, your urologist, and your primary care doctor, right?
Because the chances of you having urinary symptoms is also extremely, extremely high. Some of that can be explained by the anatomy of the prostate, meaning that we do find that men who have a median lobe, that part that grows into the bladder, that their offspring are also more likely to have a similar shaped prostate. That always doesn't go hand in hand, but similar. It doesn't get as much attention for BPH as it does for prostate cancer because, in general, no one's really going to die from their BPH these days, or shouldn't die, because if you can't pee, most men will seek out help. But it is one of those where we do study it, because understanding the genetics of BPH helps us distinguish some of the noise of prostate cancer screening, because we do know that if you are at risk of BPH, those men, for the most part, have a different risk for prostate cancer. So only about 30% or less of men will have a risk of both prostate cancer and BPH. And we can quantify that by genetic testing, and we can actually help counsel patients to say, hey, you're more likely to have urinary symptoms, you're more likely to have prostate cancer. This will help better understand our screening and interpretation of our screening tests, such as PSA.
So wait a second. Are you telling me there's a BPH genetics test available?
There is.
And where is the guy? I've gone to the pharmacies. I haven't seen any BPH genetics test. I would like to know where this is, because I'll tell you why I thought of this as I was coming up with questions for you. All the guys that I went to college with, that I was close friends of mine, all the ones whose fathers knew that they had very severe BPH, my friends ended up with it. And I remember that was the first time I thought, what is going on here? Right. So anyway, I didn't mean to distract you, but let's go back to this test. Where's this test at?
So it's not widely available, but there are several companies out there, GoPath Genetics, as well as Genomic MD or GMD, that you can get that test that will actually tell you both of those. What is your risk of BPH, those of prostate cancer? And so that's kind of cool these days, is that it's really helping us counsel patients when they walk in from day one.
The reason I said this is like Bigfoot and UFOs is because I have these Moyed BPH questions and nobody can ever solve them. So can I take you through my list?
You can.
Okay, so the genetics you answered. So nobody's solved that. So there's clearly a genetic family history relationship going on with BPH. The second one I have is that it doesn't matter what book you read, everyone has a different opinion. They say that severe BPH has no relation to prostate cancer risk, has some relation. And then there are many schools of thought lately that say you have a lower risk of actually getting severe disease because the prostate's big and there's a migration issue. There's so many theories. What say you about the relationship between having BPH and prostate cancer risk?
Again, this is where it gets a little bit more complex, is that many studies historically have noted that if you had BPH, there was a slight higher increased risk of prostate cancer. But we attributed that to a screening bias, right? So if you go to the urologist, then you say, hey, I have urinary symptoms. He also worked you up for prostate cancer. And ta-da, you magically had both BPH and prostate cancer. We did a lot of, again, the genetic studies there. And yes, we have separate genetic tests that predict BPH and those that predict prostate cancer. But we can also do these kind of cool analyses showing what is the interconnectivity of these different tests. And based on this fancy stuff, which no one really cares about unless you're in front of a computer, there is actually a genetic basis that explains both. So it is one of those where they are actually genetically related, and there is a defined association between them. Doesn't mean we can't use their tests, but understanding that if you do have increased risk of one, you are at slight increased risk of the other.
Interesting.
Depending on whether you see a urologist or not.
And how do you feel about, you talked about this, which I thought was awesome. How do you feel about someone that's dealing with chronic inflammation of the prostate, prostatitis? How do you feel about that relationship with BPH and or prostate cancer? Because a lot of people don't realize, what you study in school is you study that an infection can cause prostatitis, and then that could raise your PSA. And then you look at the data, and the vast majority of people that have prostatitis are these chronic prostatitis, non-bacterial. So all these men are walking around with chronic prostatitis. How do you relate that to your talk and BPH and prostate cancer?
I usually simply say there is a relationship. It is complex, and certainly just because you have inflammation on a slide doesn't mean you're ever going to be symptomatic from it. And certainly it doesn't mean that you're going to get prostate cancer, period. However, my general thought is that the more prostate tissue you have, the more likely, so in BPH, and the bigger your prostate volume is, the more likely you will see evidence of inflammation there. And we know that whether that inflammation is derived because there are, normal bacteria that live there that are causing that, And certainly a lot of the microbiome studies these days are suggesting that maybe that's some of the cause there. Maybe this is from other disease-associated causes, meaning that you have psoriatic arthritis, which you're like, how can that present? But it may mean that your body is just revved up so that you have sites of inflammation that can influence it, or Crohn's disease. So I think we have to pay attention to that. I think controlling or limiting the amount of inflammation in the body when it seems to be out of control or super normal is probably the prudent thing to do.
Yeah.
Not just as a sole isolate, like I have a biopsy of a prostate tissue and there's something. No, but if someone is symptomatic or have those other causes, I think it's a good idea to get that under control.
Love that. Now, here's what I've always found interesting. This is the third Moyad UFO Bigfoot scenario in BPH. I don't understand it. You have to explain this to me. I was telling Mark Scholes on a phone call, I said, it's really striking to me, and I've never talked to you about this. It's striking to me how when we talk about prostate cancer, the words active surveillance, okay, it's accepted, watchful waiting. But when you look at the history of BPH, prostate enlargement, there's clearly a spectrum of men. There's men that have mild symptoms. There's men that have moderate, severe symptoms. And then there's this group of men that have whatever type of symptoms. Let's just call them mild or minimal, and they never move. They can be on active surveillance for BPH, which may explain, the natural history is. So where are you with active surveillance for BPH? Is that such a thing, or I've been drinking too much moonshine?
No, I mean, in general, we call it watchful waiting, whatever that means. It means that we are just content with not doing any type of intervention. These men come in, and some of them have more severe symptoms, but they're not bothered by it. Some of them have minimal symptoms, they're not bothered. Some of them, as you said, they never seemingly get worse. I think some of it is defining the phenotype, because urinary symptoms, the way we report that out, whether that's with the IPSS questionnaire, whether it's with the Learn symptom questionnaire, doesn't make a difference. It's subjective. And as men or as a gender, we are not always the best at being proactive with our health or reacting to our urinary symptoms. And the interesting thing, or the difficult thing about urinary symptoms, is for the most part, it's not a on-off type experience, meaning that it's a slow, if I will, strangulation of the bladder. So it's, hey, I'm slowly noticing over time I don't urinate like I was 20. And I feel that, again, as a stereotype and not using really gender in any specific way, but that a lot of female gender tends to be a lot more proactive in that way. They notice a slight change and they're at the doctor and they are ready to do something about it. As a stereotype, we're just a little bit more sluggish. Hey, I can live this way. I've been living, you know what? I'm doing okay. I'm playing golf. I'm doing all the things I want to do. But yeah, I may go to the tree a little bit more to urinate on the hole. It is something that we just generally try to live with. And that's not right, but it makes characterizing our treatment a little bit more challenging, because it's not until men are truly bothered that they typically seek help. And that is very different. So this concept of watchful waiting, a lot of men kind of put themselves on, because hey, I'm just living life this way. I'm fine. I may be getting worse. I may not be. We don't really know, but I'm not going to come and bother the urologist yet.
What do you see in your practice and in general in the literature about little and big prostates in a relationship to symptoms? There's always that adage that just because you got a big prostate doesn't mean you have big symptoms, and just because you have a little prostate doesn't mean you have minimal symptoms. So where are you with all of that?
I think that that's kind of like the most fun part about urology in general, right? Is that if it was easy, everyone could do it. But I think that BPH, prostate cancer, are truly complex diseases, meaning that just because you have prostate cancer doesn't mean you need to be treated in X way. And similarly, like BPH, just because you have a certain size prostate doesn't mean you're going to have urinary symptoms, etc. In general, there is a correlation between prostate volume. The higher the volume, the more likely you are going to have urinary symptoms. But again, that is not a one-to-one relationship at all. And as you know, and as you just stated, is that you can have a small prostate and tons of urinary symptoms and truly be obstructed by that prostate. So it is one of those where you have to understand that. And the cool part is I brought up is that it's not just the prostate, but understanding the other associated diseases that a patient may have contributing to urinary symptoms is also so important.
Here's another one. I don't find this to be my Bigfoot or UFO. I'm just gonna whine for a minute. So let me whine about this. So you got BPH, you got prostate cancer. And so I had to do this for the audience. I had to do this educational update for physicians. It was going to be on what you can do to reduce your risk of prostate cancer or aggressive prostate cancer. And then they also wanted me to talk about other urologic situations. So I decided to make a table of what might reduce your risk of prostate cancer and then a separate table for BPH, right? And I'm doing this table and I'm looking at it, I'm going, wait a second, this is the exact same advice. So I combined the table and I called it, this is the advice for reducing the risk of prostate cancer or aggressive prostate cancer and BPH. So all I have to say is I haven't seen another urologic condition that may be improved. I mean, of course, there are probably others that may be improved or reduced in risk and severity than doing heart-healthy lifestyle changes and BPH. But I hear crickets. I don't hear much about it. So do you have any comment on that?
I 100% believe that, and again, you can see my bias here, but I think that the prostate is the heart of the pelvis. It's the brain, a brain of the pelvis, the heart, but it's the most important organ there. And just like we treat our heart a certain way, our brain in a certain, it's the same concept. We really need to focus in on treating ourselves right. We don't go out and eat a whole bunch of Twinkies and say, hey, my heart is happy and healthy. Same exact thing for the prostate. We have to keep that blood flow to the prostate. We have to keep it, happy and healthy. It's going to prevent all the inflammation. It's going to prevent it from growing. It's just every study has really kind of showed that. And actually recently, we showed and presented on that if you're genetically predisposed to BPH and you exercise, those men who exercise most, actually, they curbed the subsequent diagnosis and or treatment for BPH. So again, even if your genes point at a certain way, it's showing how lifestyle can modify that.
Absolutely. Heart healthy is prostate healthy, baby. Heart healthy is prostate healthy. Do you ever talk about with patients the importance of just knowing your prostate size? Because let me tell you why I find this very interesting. It's not like guys go out to a bar and go, hey, my prostate size is this big. How's your prostate size? But in reality, I find it very odd that there are not more commercials or advertisements about somewhat trying to find out your prostate size, because look at in active surveillance, we have this thing called PSA density, where you can't do the calculation, whether or not you think it's relevant. You can't do the calculation without an accurate calculation of prostate size. So you know the data where if you do a rectal exam, you can guess, but I think you got a better chance of someone guessing your weight at a carnival or something. You know what I'm saying? So we have all these imaging techniques. You have ultrasound, you have the PET CT, you have MRI, all these things that can pretty accurately guess prostate size. And it's such an important thing to know in general. Where do you stand with that kind of knowledge?
I'm biased. I want to have it on everyone because it is one of those that it just, in the interpretation of so many things, it helps us get our pretest probability. Whether you're more prone to prostate cancer, if you put that in relation to PSA, as you just said, whether you're more likely to have urinary symptoms, the size, the shape. And these days you can do it in so many non-invasive ways. Like you don't need to have a transrectal ultrasound. You can have transabdominal. You can get it from a CAT scan, an MRI. You're going to have at some point some imaging of your pelvis for something statistically. And so if you have that, just ask the provider, say, hey, can you just calculate what my prostate size is based on that? It puts you in the ballpark. Knowing it may change and grow throughout your lifetime, at least around that area, you can get an estimate.
I love that. I didn't know that you were pro prostate size.
Love image, love
The
prostate
things
image.
I'm learning about you today.
I'm
You're really
telling you.
getting a lot of favor with me. For the audience, they don't realize that he made me do this interview with him on the day of my wife's birthday. So, of course, I'm going to pay big time. I'm probably going to sleep in this chair tonight.
For
But the
sure.
reality is, you were worth it. You're worth it. So, I'm
I,
going to go to have a nice dinner. So, I love that. So, now let's move
a
on
hard,
to.
healthy dinner. A hard, healthy
I saved this one because this is from a publication I did in 2003. Heart healthy, prostate healthy. You know, I find it so interesting that the first drugs used for essentially prostate for BPH in terms of the alpha blockers actually really came from blood pressure medicine. You lower blood pressure, it's good for your prostate. Anyway, I'm not, you know me, I'm not going to stand on this. All right, now I want to go to something for the audience, which is important. And before we start talking about the medications and aquablation and anything else, I want you to talk about the goalposts. And I'm sorry to bring up a football reference because your team is not good, but I have to.
You don't know. It's a new season. It's a
I
new
know,
season.
but now it's all the best team that money can buy, right? That's the only problem. So
That is
now we
true.
won the national title, so I
Yeah.
don't care if we get clobbered anymore. I can now sing to my
Just had to
grave.
bring that up. I see how you conveniently work that in.
Like, it's only football, man.
That's
But
right. That's
when
right.
we win, it's more
Right.
than football. It's about life.
That's right.
When we lose, it's all just football.
Completely.
All
Completely.
right. I want to talk to you about measurements because everybody's thrown out this vernacular, right? They're thrown out BPH vernacular. And I want you just to, in your opinion, tell me why this makes a difference. And this is why people with BPH should understand this. So you mentioned a questionnaire called IPSS. There's another one called AUA symptom score. And you fill this out. I've got it here. And then you've got one that you've talked about, and we won't go through them all, but you know, it's important that when you're on a pill or being treated, that you see a change in these symptom scores, right? That they get better. I mean, can you comment on this? Shouldn't everybody fill this out before they think about even any treatment?
I mean, 100%, it's not only you should, it's recommended by our guidelines, et cetera, because it's the only quantified way to understand what is bothering you, right? So you
Yes.
may have tons of bother, but it may be related to something we can treat or not treat, but it also serves as an objective way to see how you're changing and improving. And
Yeah.
so that's really where is it first helps us understand what is the severity of the problem. And if you do have treatment, or even if we're watching you, how bad is it getting, or how bad did it, how much did we improve you? So
Yes.
it's really, and it's simple. There's no cost to it. There's truly no cost to it.
So why doesn't everybody fill this out before they go into the urologist? Why are people filling it out while they're there? Because your waiting list is so long, or your waiting times are so
In
long?
my clinic, you actually you learn to hate me because I have you fill out so many questionnaires before you even come in. They're all online, so you get a reminder several days before. You go online, you fill out all the questionnaires, then they're automatically dumped into our computer. So at the time I can say, hey, Mr. Smith, it looks like you have X, Y, and Z, and this is how severe it looks like. Let's talk about this for a second.
Yeah.
It really is a way, but I do subscribe that this should be filled out ahead of time by the patient themselves.
Thank you. I don't think anyone should go see the great Helfand. I just don't unless they fill this out and they understand what they're filling out. It is such an important, in cardiovascular medicine, people have all these different risk assessments and questionnaires and, Framingham risk score. We know all these names, but this is such a key component to tell the physician and the team, your medical team, how you think you're doing, right? And the higher the score, for example, here, the more the severe symptoms, the more possibly severe your BPH. So I'm so glad you've endorsed the idea that you should do the Learn or whichever one that you prefer. Any more? I don't know if you have any other comment on that because I'm about to chuck it.
Well, I think it's imperative you fill it out.
And we already talked about knowing your prostate volume and size overall. We talked about that. How about this thing called PVR, post-void residual? Can you explain to me why that's so important to urologists, knowing your post-void residual? And isn't it okay to have a little bit of urine left after you go pee-pee?
Everyone has a certain amount of urine. Actually, almost no one ever empties. Even when it says 0, you still can find a little bit of urine in there. However, as men age and we say our prostates grow, that it can block your bladder, to some degree, that you start accumulating the amount of urine that you hold on to after you pee. And certainly for most men, even if you hold on to a little bit, meaning 100 or 200 milliliters, it's fine. But there are some men that, chronically will start accumulating many milliliters, so 1,000 milliliters,
Yeah.
a whole milk jug of urine in there. And sometimes for some of those patients, that can be so much urine that it actually backs up into the kidneys and does some damage there. So it is one of those where we do pay a lot of attention to it. And just because you have an elevated amount of urine that you're holding on to, number one, doesn't mean it's always because of your prostate.
Yeah.
But also, it at least serves as a discussion point for how we can better treat you or prevent it. And sometimes we don't even need to treat it, but other times we definitely do. So that is
Yeah.
something situational, dependent.
That's a really key measurement. And the last measurement I want you to mention, then I'll move on to my next questions for the sake of time, is this Qmax or flow rate. Why does everybody tie the success of their treatment to your flow rate? And can I just determine my flow rate at home? Or do I got to go see the great Helfand in order to determine my Qmax or flow rate? Why? So my first question is, why does flow rate make a difference? And how are you going to measure it? And can I do that at home?
All of this data, whether you're talking about post-void residual or prostate volume, we're all trying to accumulate evidence to say this is most likely from your prostate. Certainly, if you are blocked because you have an enlarged prostate and it's blocking the exit from your bladder, that you may have a slower flow, right? Because the amount of urine you can pass through a smaller opening at one time is limited based on that opening size. So we use that as evidence to help support it. Is it the most accurate test? No. All of these tests that we've talked about have some error in them. And if you don't have a full bladder, or the effort wasn't there, or there are other reasons causing, you may actually have a low flow and may have nothing to do with your prostate. But again, it's all serving as a piece of data that we want to help us better understand what the source of your urinary symptoms is from. You can do it simply, even if you wanted to do it at home. You could take a stopwatch, you can pee into a measured jug, and you can actually plot out how long it takes you to empty your bladder. It's possible. Is that the most accurate way? No, but it's a simple way that we can do it if you really wanted to. You can, when you go into the urologist's office, there's actually a machine. It's not invasive. You just pee into a funnel, and that can measure how fast your urination is going. There are even other devices in the office, again, non-invasive, that we can put a cuff, a little blood pressure cuff onto your penis that you can actually even more accurately potentially measures the pressures as you pee. But these days we're like so cool and so advanced. There are even applications on your phone that will listen to the sound that you make as you pee, and that'll actually kind of determine how fast you pee over time, that are more accurate than just taking a stopwatch and going. So there are a lot of cool things in that space. Again, to the patient, understanding that you can do this all by non-invasive techniques.
That is awesome. But clearly there is a relationship with the greater the flow rate. I know it's in mLs per second. The greater the flow rate, in general, the better you could be potentially doing and the better response you had to a treatment, right?
Correct. So it is another piece of data that you can monitor, meaning if you were slow before a treatment, we do some type of intervention surgically or medically, you have that person repeat the test, all of a sudden the flow is better. It's another piece of data to monitor.
Well, I think I've been sort of hurt by my flow rate. I think my flow rate is probably outstanding because when I'm in a public restroom, it's very loud, it's very fast.
Yeah,
And
you stand
there are
back.
other men, there are other people that look at me and I can see, I know what they're thinking. They're thinking, that guy's got incredible flow rate. What's he doing? One other thing that patients should be aware of, because this word's coming up more often, I thought you could comment, and you don't have to go too much, is that I saw on a number of websites from all these academic centers they're starting to use the word, hey, if you go see a urologist and you're having bladder problems or prostate, you can get these things called urodynamic tests. And there's all these types of tests. I don't know if you have any comments. The word urodynamics has become such a word that gets people excited about measuring all the different aspects of your prostate and bladder and urinary flow. Do you have any comment on, are you supposed to ask for a urodynamics test? Where are you with this?
People have various emphasis on using urodynamics. I do use urodynamics in my practice. I use it to document a lot of times bladder function. So
Okay.
again, for people who don't know, the way that it works is you come into the urologist, you go into a separate room, you get undressed from the waist down. They insert little tiny catheters. So not like a normal size catheter. It's generally not uncomfortable at all. In that way,
Yeah.
it's slightly invasive, but they fill up your bladder with some fluid, and then they measure how your bladder responds in terms of pressures. And then they have you pee, avoid, and they can measure all the flow as they do that.
Okay.
There are certain times you can even get pictures, X-rays, as you do that, and we call video urodynamics. And that again gives us an idea, is it a low flow, high pressure voiding, meaning is your bladder generating a lot of pressure because it can't squeeze through all the urine out? Is it low flow? We can get all of that data. Is that really necessary for most patients? My belief is no, for most patients, it's not going to actually change what we do. On the other hand, there are complex patients, those who I believe had either had prior surgery, so we're trying to re-demonstrate that, hey, that surgery didn't work, or that patient has a neurologic disease, they have multiple sclerosis or Parkinson's, so we're trying to understand better of, is the cause of their urinary symptoms the neurologic disease, or is it actually the big prostate? That's the setting that we're trying to use the urodynamics for. So I traditionally don't use them on most patients,
Okay.
but it is that select few. For many places, they use it because they're trying to, get study information, and so that's a different discussion.
So it's not bad to go if you're going into your local urologist to say, are we going to do any urodynamic studies today to figure out what's going on? I mean, I think it's a little empowering.
Yeah, I mean, it's a little bit more scientific way to get that information that may help better choose the right treatment for the patient.
You know what the biggest fib ever told? I made this, and I want you to acknowledge this. The biggest fib ever told, and men are all guilty, I think, of this as we get older. I hardly ever wake up at night to use the bathroom.
Yeah, most men
You look
will
at the
wake
partner,
up.
then you probably look at the partner and go, what's the real answer?
Totally different story. We tend to underestimate. And the issue there is that we also, bother from nighttime voiding, getting up in the middle of the night is typically the greatest. That tends to be the most bothersome symptom, most motivating symptom that men have.
Yeah.
Understanding that as we age, we do make more urine at nighttime. Our position, laying down makes us have more urine. Many of our hormones change through we age, etc. So some of it's normal. I always tell men that 2 or less times a night is actually in the normal realm.
Really?
So it shouldn't really, motivate in and itself if you have 2 or less times the sole reason for treating you. But there is, kind of even ways to distinguish some of that stuff out. If you have what we call primary nocturnal polyuria, you're making most of that nighttime volume at night. So there's fancy ways to look into that. But, for most part, we all should expect to get up at some point during our life to have to urinate, and that's okay.
I decided to make a list. I made 2 lists. It's a pretty extensive list. So can we go through these and I like the game called the Moyad Pro and Con game. Can we talk about the pro and con? Let's talk about, first of all, before we talk about any of this, I saw this online doing research for you because I had to update my BPH skills and just knowledge. I read in a few places that this is true, up to 30 to 33% of men fail prescription medication within 2 years. Is that true?
It is actually, and some studies would actually suggest it's even up to 67 or more percent. So it depends on your population, and you're like, hey, I went to the doctor and I hate their medicine, so I stopped it, right? This happens all the time, but it's okay because we are giving these medicines to improve your quality of life based on your urinary symptoms. And if they're not helping, talk about it because there are treatments for you. They just may not be medications.
That's an incredible statistic, you know? So let's talk about the first type of pills offered. You can say a pro or con or not say anything at all. I just want to make sure we cover this before we just talk about, again, aquablation and the other more invasive treatments. Although these can be kind of invasive on their own. Alpha blockers, right? Alpha blockers are the top of my list. They end in -osin. In general, like alfuzacin, doxazacin, anyway, there's Flomax.
Amsulosine,
So
silodosin, yeah.
they relax the prostate. That's the good news. I don't know. You want to add any more good news or bad news about the
Well,
alpha blocker?
they are some of the initial medical treatments for BPH. Again, as you brought up, and a lot of them were kind of coincidental because we said, hey, we're using these to treat your blood pressure, and look, you're peeing better. So they do relax the vasculature and certainly smooth muscle cells of your prostate. Which takes off some of the resistance from your bladder, so help men. They do, most of them have some side effects. The two main ones I always counsel patients are as the possibility of retrograde ejaculation
Oh,
and
good
the
point.
possibility of, it's not usually orthostatic, but at least lightheadedness and dizziness. So certainly counseling, understanding that beforehand can at least help have patients more compliant with the medications, knowing that before they start them.
I want you to see if I can take you from the great Helfand to the super great Helfand. Do you notice that every single website that talks about alpha blockers talks about retrograde ejaculation, but nobody says what you're supposed to do about it? Do you have to quit your medicine? Do you get treated for it? Nobody ever says. They said, oh, you're going to have retrograde ejaculation. Gee, thanks. But it never, the website never continues. I don't know. And I haven't seen any website continue to say, well, what are you going to do about it then? What do you do about it if you have it?
You can't really do much until you stop the medication, and then it comes
Yeah.
back. Now, there are other forms of alpha blockers, so not all alpha blockers have the same risk of retrograde ejaculation. Alfuzacin is actually a lower risk than tamsulosin, which is lower than silodosin, et cetera. So discussing that with your provider may help it, because there may be an alternative that can help alleviate your urinary symptoms and not give you such great risk of sexual dysfunction.
But if you have it, is it bad to have such a thing? Is it bad to have retrograde, or is it just
There's
more
no harm
bothersome?
unless you're trying
No
for
harm.
kids, or a lot of men will, without any judgment, will define their sexual prowess based on their ejaculate volume. And so for them, there may be some, kind of negative connotations there.
Yeah, that's understandable, but you just solved all the internet's problems in a couple cents. Nobody ever tells you what you're supposed to do with it, but you just did. Thank you. 5-alpha reductase inhibitors. They shrink your prostate. They
shrink your prostate. They may shrink other things. So they shrink your prostate by altering the conversion of testosterone to its really potent and active form known as dihydrotestosterone.
Yes.
They are good in the long term in that they can reduce the possibility of progressing, getting worse urinary symptoms over time. They do improve urinary symptoms by themselves. They generally take about 6 months before they're actually fully working. They do have some negative side effects, meaning that there are a certain population of men, about 5% or less, that will have true new onset erectile dysfunction that has been reported. Sometimes that's irreversible. So it is something that is important to know. Men can get breast tenderness on them and stuff like that, but they can also promote hair growth on top of your head. So it is one of those where some men use them for that at different dosages as well.
PDE5, this is the other treatment for BPH, Cialis. People think of them as erectile dysfunction drugs, but they may actually help with prostate enlargement. How did an erectile dysfunction drug become an option for BPH? And can you just clarify that this is not the same as sexual activity? You just take it daily as a medicine. There doesn't have to be sexual activity. So
correct. So it's taken at a lower dose.
Okay.
The FDA approved drug is the tadalafil. which for sexual activity is generally provided at between a 10 to 20 milligram dose. For the benefits of urinary symptoms, they have it on a daily dose at a lower dose at 5 milligrams, or in certain populations, 2.5 milligrams. And so that was initially noticed that, hey, men who were taking this drug also had a stronger stream. And when they looked at it and, kind of studies of the bladder, they said, hey, it actually improves because it relaxes the musculature of the floor of the bladder. And so it actually was shown to be an effective treatment. Again, they can be used alone, or they can be used simultaneously with, some of the other medications. They in itself also can help that nighttime voiding.
All right. You can just say something about why these overactive bladder drugs get a lot of attention with urologists. Here's, ditropan, and then they got these other ones, these beta-3. So you've got these drugs for overactive bladder. Do you use them much? And what should I just know about that?
Certainly there is some caution and guidelines these days because of the association between a lot of the historic, what we call anticholinergic drugs. There is an association with, kind of potential future for dementia and, kind of altered mentation, that there is a kind of a red flag there. They themselves, because of their systemic side effects or interactions, they can increase your risk of dry eyes, dry mouth, constipation. So, kind of more recent versions of the OAB, overactive bladder guidelines, that in general, if it's possible, you should consider a beta-3 agonist first, because of the potential for lower risk side effects. So that's maribegron, verabegron, etc. Those themselves, the beta-3 agonists, are great, but not always the most practical because of cost. Even though the maribegron is an example, around for a long time, a lot of patients find them still very expensive or not covered. So again, should be discussed risk-benefit of each one of those. Those are intended to help urinary symptoms, but specifically, a lot of them for irritative symptoms, urgency, frequency, getting up in the middle of the night, those potentially can help. The question I always have there is the primary issue an overactive bladder, which those are great for, or is it really the prostate driving the overactive bladder, and should you just be addressing the prostate first? But that's a different discussion.
Do you want to say anything about Botox for overactive bladder? I mean, I know it's been around for a bit. I mean, I don't know if you give it. I just thought we get questions.
Botox helps a lot, especially if there's an underlying neurologic or other cause to it. Again, in terms of BPH, I always think that you should address the outlet, the prostate first. If you still have persistent OAB symptoms, then Botox is a consideration. Again, a lot of the therapies, especially according to the latest OAB guidelines, can be used as, sole therapies. You can start off by using, kind of a medication or Botox, but certainly they can also be used in combination if those irritative symptoms persist.
Last but not least, I'm going to throw in the one that's going to just throw in some fireworks. You ready?
Here we go.
Extracts, big sellers in BPH, herbal products, saw palmetto, beta-sitosterol, pygeum. I mean, where do you stand on these? If someone comes in and says, hey, Dr. Helfand, I don't mind if you do aquablation or whatever you're going to do, but I still want to take my herbal product over the counter. I mean, this is a whole other lecture, of course, but where's your just sweet spot on this?
My stance is, in general, they're not considered harmful. Meaning that most of them, are safe to take. There are very few true randomized trials that have really evaluated their efficacy. The other problem is that a lot of the kind of natural therapeutics are different. So there's not a standardized way that they're sold. And so you don't actually know the amount of any of those kind of active ingredients that you're taking, which makes the interpretation variable. But if they are helping, then please take it. I was involved and helped analyze the Camus trial, which was a randomized trial of looking at saw palmetto at 2 different doses versus a sugar pill. There you go. And ultimately, it's one of those where there was no difference in outcomes for most of those patients. So it's not one of those where it's wrong to take, and I certainly don't stop patients. But knowing that you have the expense of buying the drug, and while it's generally pretty affordable, if it's not helping, you can stop them.
Yeah. And yeah, I think they should be cost competitive, quality control, all this. I mean, like I said, I could give an 8-hour lecture on it. I just want to know where you stood. I didn't know that you were a part of this Camus trial and analyzing it. I'll
That's
tell
where
you
we got
what,
all that sleep data from. It was the analysis of the Camus trial.
a
Yeah.
very famous trial for the audience in my world. And it was, but what we learned from these trials that I always try to remind people is that in the STEP trial, which was before the Camus trial of saw palmetto versus placebo, Bent et al., it was they did this placebo run-in phase, right? And during the placebo run-in phase, there was a significant benefit in urinary scores during the placebo run, meaning that I don't care if it's a drug or a supplement, there is a placebo response rate in BPH, which is quite
Huge.
substantial, right? And it's not just the herbals, it's just with any of these pills in BPH. And so you recognize that there's a very large placebo response rate. What made my head spin last time we talked about whole lip, whole lap, whole lip, it doesn't matter. You say potato, I say potato. I mean, when you look at the number of choices, I mean, this is just a partial list of BPH choices. And then I tried to put them in an abbreviation. I mean, come on, you got to admit, if you're a patient looking at this, you're saying, what kind of mess is up going on here? How am I supposed to figure this out? So here's what we're doing at PCRI. It could be right or wrong. We're just trying to focus in on an expert that does what they do. You already talked about the others. And I just want to go through a checklist of what Aquablation provides or not. And then I think we're doing a service to the public. The idea that we're going to go through every single one of these, we would have to have 36 hours of tape. But it just goes to the point of doing your homework. And so I don't know if, let's just go through these and then we'll be done. But I want to go through questions that you might get if someone's interested in a procedure for BPH. Most of the, if not all the men you treat have moderate to severe symptoms. These aren't guys who have mild symptoms and it's just a little bit nagging. Is that correct?
Correct. I mean, most of the patients are treatment seeking, right? So these aren't people who are living in watchful wait. These are guys who come in and saying, "Hey, I'm bothered by my urinary symptoms. I'm not happy with my current status, or I need help." So
Okay.
that's most of those are going to have moderate to severe symptoms.
Okay. Does it matter how old you are, being too old or too young to get aquablation or some of these other procedures? Have you treated some very young guys and some older individuals? Sorry, we can't use
100%.
the word older anymore. The word seasoned. Seasoned.
So we were initially limited because when the insurance approval happened, they based it on study criteria, and you never involve men 80 or older in studies. So we were initially limited there. Now that age restriction has been lifted for a while.
Okay.
So any man who is deemed a candidate for surgery is qualified. And certainly because of the low risk of side effects, that even young men who are determined to be obstructed from their prostate or have urinary symptoms because of their prostate are candidates for it because they don't have the sexual side effects that are typically associated with most resective type procedures.
Next on the list is, and this scares me a little bit about aquablation, maybe it shouldn't, anesthesia. It sounds like you're telling me I got to be wheeled in and get general anesthesia, right?
You can have spinal anesthesia.
Okay, you can have
You can have LMA, so kind of where the tube is only in the mouth, or you can have full general endotracheal anesthetic. The only anesthesia that is not currently used is a twilight MAC anesthesia monitor.
Okay, so Twilight's okay. But should that be scary? It sounds like this is not done in the office. This is done in the hospital. No?
You should be done in the hospital only because, and most men, in my experience, are actually happy with that because they just, when it comes to down there, they said it's a very sensitive area. I don't want to feel anything. And that's not wrong. And the only reason we do it in the hospital is because it's a lot more comfortable, because it turns out if you take a water, power pressure to your prostate and you're awake, it's stimulating. So to make that reasonable, we do it in
Okay.
there.
Antibiotics. Do you have to use them before or after? Like, what's the deal with do I have to take antibiotics?
Just like every other, almost every other urologic procedure, we usually just give one dose right before surgery in the
Okay.
operating room. That's it. The only exception there is that for my protocol, that if you're in retention, meaning catheter dependent before surgery, I will send you home with about 5 days of additional antibiotics just to prevent any bacterial seeding of that freshly treated tissue.
Okay. So short course before, maybe some after. Big prostates. Here's what I don't get. You have to explain this to me. I found this article you wrote in the Canadian Journal of Urology. Brian Helfand, How I Do It. Aquablation in very large prostates, greater than 150. I'm going, I didn't know aquablation. I know you say it, but I didn't know this is becoming more accepted for huge prostates. Is it, or is it just you?
No, actually, when you look at the trends across the country and you look and saying like, well, how do people really start off? The initial studies were all done in 150 grams or to less to 30 grams, or 30 to 150 is a better way to say it. And then, but in the real world, because it's a non-invasive and very easy way to treat patients, when urologists first acquire the technology and they start using this, most of the patients that are referred have huge prostates. So what is the real difference between 150 and 200 and 200? It's not. It's made so easy. So it's really kind of in that way, really size agnostic. I think the largest prostate that has been done with aquablation now is about 730 plus grams. So a huge, huge grapefruit. And apparently that was not done by myself, but that individual is urinating without problems. They were in retention beforehand and very happy with the results.
I think the dumbest thing that I ever see on the internet, sorry, it's not the dumbest. Maybe I don't like it. They say a prostate's the size of a walnut. Yeah, maybe when I'm 16, it's the size of a walnut, but I know that you're seeing people as the size of a football, not
That's
to
yeah.
throw,
Oh,
not to
not
throw,
that football, not that one.
no, maybe not that, but it's just like, when did this become the standard?
Well,
Forget it.
it is funny that we refer to most prostate sizes as like fruits or food groups.
When I'm watching videos or trying to learn more about aquablation, it says that one of its Achilles heels on my checklist is potential bleeding. Is bleeding or the need for a transfusion very different? Just because you have blood doesn't mean you need, just because you're bleeding doesn't mean you need a transfusion. But is that truly an Achilles heel of this procedure?
No, and I fault, and I was not part of, and I'm still not part of Procept at this point. But when Procept designed their trial,
Yeah.
their second trial was known as Water 2, and they kind of had it wrong, right? So they thought that any type of cautery energy was going to cause retrograde ejaculation because they just didn't understand where the antegrade function was really coming from. It turns out it's from the veru, the apex of the prostate, because you can destroy the bladder neck. That's a whole different story. But because of that and that fear of having sexual dysfunction, what they did in Water 2 was they said, well, we're going to see what the worst case scenario is. We're going to take the worst, biggest prostates up to 150 grams. We're going to do aquablation with a water jet, and then we're going to walk away, put a catheter in, and call it a day. And there is no other thing that you would ever do as a surgeon to say, what I'm going to do is intentionally cause disruption of tissue, cause bleeding, and walk away. But that's what they wanted to do, say, what is the worst case scenario? And even in the worst case scenario, it was a 6% significant bleeding rate, which you said, oh my God, that's really high. On the other hand is now that there's protocols and the way we do it is totally different, that rate of significant bleeding is about 0.4%, which is actually lower than TERP, the gold standard. So it's not a significant worry or bleeding risk. It just initially, based on that initial study, which people didn't understand, was associated with it.
Okay. What about blood thinners? If I'm on a blood thinner, can I have this procedure or do I got to stop it?
If you're in my hands, and again, there's no written protocol, but most people would say is that I am okay with you being on a baby aspirin
Okay.
throughout the procedure or ibuprofen or something on that.
Okay.
But if you are on a anticoagulation, a true anticoagulant like a Coumadin or Pradaxa or something in that space, that we usually have you hold it. I
Okay.
typically will hold it for about, depending on the blood thinner type, for about 24, 48 hours before the procedure. And then we restart that 4 days after the procedure. That
Okay.
type of protocol is really just based on more of historic what we do for other outlet procedures. So there's really no difference there. The only patients I won't actively offer aquablation to is if they've had a fresh cardiac stent,
Okay.
heart stent. They cannot come off their blood thinners at any terms for a period of time. We will not do that procedure at that time. But I don't actually know of any real procedures that they do during that time.
If I'm a larger person, BMI wise, waist circumference, am I okay here, or this is it necessary larger operative time or anything? What about a very large individual?
I mean, there's the usual risks of any type of anesthetic if you have an increased BMI, et cetera.
Yeah.
I don't really haven't seen a BMI as a factor here at all because again, this is all endoscopic with small cameras through the urethra. Medicare, I believe, has a limit there. I'm not sure what that is based off of, but I think they have some upper limit that they wouldn't allow us to approve or proceed.
Catheter. Do I have to have a catheter in?
Again, this is variable based on the surgeon. We generally leave it in at our institution overnight
Okay.
for just really about 12 hours after the procedure. The catheter is removed in the morning. There are some protocols based on surgeon preference that may leave it in for several days, but in general, it maxes usually about 2 days.
Okay. Do I stay overnight in the hospital, or can I go home the same day?
It again depends on surgeon preference. Right now, the company would say you should spend overnight in the hospital. Having said that is largely based on COVID. We and others developed an outpatient protocol. So for certain patients we have with 150-gram prostate or less, it is possible if motivated, you can go home that same day.
Okay.
There are now surgery centers across the world that are trying that out that have had a lot of success with it. Again, surgeon preference and patient preference driven.
So not always. That's interesting. Insurance coverage, right? Major insurances, Medicare, the
Covered
works.
by, correct.
I don't want to be patient zero. I don't want to be the first or second person getting the aquablation. I want someone that's done it hundreds upon hundreds of times. Tell me if there's a learning curve. And if you say there's no learning curve, I'm going to go, what? There's got to be some learning curve, but I'm saying that, but tell me how many procedures am I looking for when I can feel comfortable? I know it's really hard to pick a number, but if someone's done 100 or 50, can you just give me some guideline on this?
I always say that at least talking to most urologists is that the learning curve here is generally 10 to 15 procedures. Just because, again, remember the technology involves things that urologists do all the time anyways. It involves an ultrasound. These days, especially in biopsy areas, we're so used to looking at prostate ultrasounds. Two, it
Yeah.
involves cystoscopy. So there's just the basic skill set that we have here is there's not a lot that is really needed.
How many have you done, roughly?
Just under, I think, 500.
Okay, so you've done 500. So I don't expect you to have any sort of reaction to this, but I would rather see someone who's done 500 than who's done 15. I'm sorry.
Well,
I'm not asking you to react. I'm just telling you. I'm telling you what everyone's thinking watching this, because I know that's what I'm thinking, but that's good that you've done 500. But I mean, what you're saying is you don't need that much of a learning curve, which I appreciate, but I love the fact that you've done 500. I had no idea you've done 500. I thought maybe you did 200.
It's one of those where that's with anything else. I do think that having specialty in a certain area helps. But it is one of those where the beauty is that it is compared to a lot of things like whole lep, where the learning curve is well defined. It's saying, hey, you need 250 or more, which takes many, many years to accumulate that for most urologists, that this is can be done and learned very quickly.
Remember my last interview was on whole up. I was impressed. So, I was
Well, there you
impressed by
go.
the learning curve of that individual, but that person was at Michigan, so I'm always impressed by anyone.
Well, there you go. There you go.
So, but the goal has to be, and this should always come up in a conversation. The goal in aquablation has to be the goal in other treatments that if someone's on medication, the goal is to have them come off completely, correct? Or am I
Correct.
wrong?
100%.
So
And
so if I'm on Flomax, I'm on Cialis, I'm on finasteride, dutasteride. Our goal is that when I'm done down the road, when I get my results, I'm not taking these pills anymore.
correct. So
Okay.
the normal protocol that we have is that you would continue that medication for 1 month after
Okay.
surgery. That's
Good to
not
know.
based on any real data. That's been our standard. And then you stop all medicines. And then, we continue to follow you. We keep track of everything. And the rate of retreatment in our series is really less than 0.1% a year. So very few patients ever need anything again that we
So
can tell.
when you say retreatment, do you mean retreatment with the pill or retreatment with any kind of
No,
treatment?
either any medicines or surgery.
Okay. Any comment on partner perspective? The only reason I throw that into my gigantic checklist on all these procedures is that do you ever have the partner fill out an IPSS or comment on, the true severity? I know we touched upon this, but I would think in a close partnership that I'm more likely to get the best answer when I get a combination, no?
One of my collaborators and colleagues, Kevin Zorn, who's in Canada, is actually doing this and having the partner fill out sexual function and urinary symptom questionnaire simultaneously. So we'll see what that data kind of reveals.
Uh-huh.
On the other hand, what I've noticed is that, in the patient population that I treat, a lot of the spouses or partners come in at the first visit to talk about everything, and you never see the partner again. And that in a way is a good sign, because if there's a problem, you usually
Yeah.
see the partner come back.
Average procedure time?
About 37 to 42 minutes. I mean, it's pretty quick.
That's pretty quick. Average reduction in prostate size?
So the volume itself is measured by the calculators we have, which are insufficient, is
Yeah.
about 30 to 40% reduction in overall volume.
And how
The
long does that take?
actual,
Right away. So that's right away, right?
again, imaging has been subsequent in various series. Stephen Kaplan has measured kind of 40% or more reduction. He does ultrasounds more frequently. A totally different side, have a large active surveillance cohort who have had this, and kind of by MRIs. It's just a challenge to measure because they still have a big defect throughout the middle of it. So I don't know if we're really comparing apples to apples, because it's a more of a hollowed out ball, so to say.
Well, if you're getting 30 to 40%, that's a lot, right? I mean, and then so
It
what's
is, and it's similar reduction, or if not more, in PSA, which is another proxy
that
for
was my next question. So you must see pretty large PSA drops.
huge PSA drops.
So like what?
If you started off with 4, I would expect you to be about 1. A PSA of 4, and you go down. I mean, it's a significant drop.
Next time you and I talk, I'm going to spend an hour just complaining to you. And I'm going to complain to you of how this is the thing that BPH procedures in general don't get enough attention. It is really amazing to watch someone like a friend of mine have a PSA of 7, get a very prominent procedure. I'm not going to say if it was HoLEP or Aquablation or what it was. And now his new PSA is 0.7. It's 0.7. And it doesn't mean he's not going to get cancer. It just means it's just stabilized. And how many men have had these erratic PSAs from BPH? They end up getting biopsied and they end up being on active surveillance, which contributes to the overdiagnosis of prostate cancer. I also believe prostate cancer is underdiagnosed when it comes to aggressive disease, but how many men have had an erratic BPH, which led to a biopsy, which led to active surveillance?
And I'm now stuck following your cancer, which I don't believe will progress. And I tell these men this: I think your primary problem was you had a big prostate. No one factored in a PSA density or other kind of factors, saying, hey, most likely this is what it is. Let's address this. And it turns out you're really bothered by your urinary symptoms. Why have we ignored it? Why are we so? And by the way, as an oncologist here, I'm so cancer focused, right? But I'm like, in those men, why are we so focused on your cancer? Your cancer is not your problem.
but it's creating a lot of problems.
Creates a lot of problems.
That's why to corral BPH has got to be as important as corralling anything else out there. My
Correct.
dog agrees. I don't know if you heard him bark. My
I
dog's
did. I
my
did.
dog has a prostate. What's your average post-void residual improvement? Do you see we talked about PVR measurement. Do you see that improve?
100%. So the average volume for whatever this is about 150 milliliter improvement. What that equates to is I mean, also a significant improvement in urinary flow, all that kind of stuff. So there are significant sustained improvements in urination. I mean, in volumes and all that kind of stuff. Again, contributing to our success, supporting that it was a successful procedure.
And then what about flow rate, which we talked about was an important measurement? Do you see flow rate increase, or by what is it increase on average? Again, we were talking about that. I didn't need that.
Pre-op is about 5.7 mils per second, so greatly obstructed. Post-operatively, that average is between 15 to 17 mils per second.
Quality of life. Do you measure that now after
By
Aquablation?
questionnaire, all by so many questionnaires, all significant. And this is the only procedure where I'm like, hey, I don't mind seeing you 2 weeks post-operatively, because the recovery is so easy because you don't have that added energy power. So there's no real cautery, there's no real lasers. So these patients are actually quite pleasant to see because I'm not torturing them in that perioperative period. Or I should say the aquablation isn't.
So you have found, if you see these objective parameters improve, you've seen the quality of life improve.
100%.
What about radiation exposure? Does this involve any radiation exposure? People, no, okay.
No radiation.
Okay, because if you look on every advertisement for aquablation, it says image guided. I'm going, well, what kind of image? Is that giving off radiation or not?
It's ultrasound waves.
Why don't people just say what it is? It's just like, I don't get it.
No fancy stuff.
Recovery period. How long does it take to recover from this? And is there anything I can do to speed up the recovery personally?
The prostate itself, it's raw. I don't care what procedure we do. If it's a resective procedure, even if it's even just implants, that it's irritated. And so this is about a 2-week recovery period. Where you may find yourself going to the bathroom slightly more frequently. There may be some pain at the tip of the penis when you void. You may have some blood in the urine. That's the kind of recovery, if you will. If you take Advil, even that irritative pain typically goes away for most patients, as long as you schedule that Advil for 2 weeks.
So I'm a busy person. You treat me. How soon can I go back to work and or driving? Or whatever I like to do.
As soon as the catheter's out, you can drive. Again, this is not a major pain procedure, so you're not on any narcotic pain medicine. So as long as you feel like you can step on the brake, you can drive right away.
Okay.
I always say take several days off work, probably 3-4 days. Not because, again, you're not functional. You just may be going to the bathroom more frequently. So if you had your procedure on a Friday, by Monday, you'd be ready to go back to work.
Okay, when can I start running again and or lifting weights?
I say start off easy. Take several days off of heavy lifting or working. You can walk post-op day 0-1, but resume exercise building up starting 4 to 5 days after surgery. So it's not one of those where I ever. Has been no randomized trial ever showing that if you start earlier exercise, that there's going to be some detriment. And so historically, people said, well, take off several weeks. I said, why take off several weeks? So we've always had a protocol to say, if you feel up to it, drink a lot of fluids during that exercise, but it is, in our opinion, safe to start early exercise, even several days after surgery. Don't push it. I don't need you running a marathon right away.
Yeah.
But things like elliptical, walking, fast walking, maybe hold off of bike riding for several more days, but that's really about it.
But again, say that again, lifting. If I want to get back to lifting minimal weights, like in the weight room?
4 to 5 days post-procedure. Even sexual activity, I say if the opportunity presents itself, don't pass it up.
So I want you to take me though through the top side effects you see just for balance. So the top side effects you see, are these from long term or short term? Can you just go back through my head?
A lot, unlike a lot of the other resective procedures where we worry about scar tissue and things like that.
Uh-huh.
There's no really real risk that we have shown that you have bladder neck contractures or scar tissue there. The risk of kind of immediate thing is just blood in the urine. So as
Okay.
long as you're drinking fluids, most men can keep that clear where you don't have to worry that you're gonna get blocked up because of a large clot. And the only other thing that people really are concerned about is that there's, some dysuria or pain, kind of the tip of the penis when you void.
Yeah.
It's all referred really from the irritation from the prostate. And then there's a 8% risk or, up to 10% risk of retrograde ejaculation.
Doesn't come back or does come
That
back.
can be permanent. We don't really know among that subgroup if there's, kind of a recovery or not of that. I think that's
Okay.
still an unanswered question.
But I should be noticing that you treated me within, again, say that I know I'm not holding you to this, but when you treat,
Your strength of your stream
yeah.
should be almost immediately strong.
Okay.
The frequency of urination and a lot of that urgency typically resolves pretty quickly within several, days to weeks afterwards. The last symptom to kind of recover, this is true of almost every outlet procedure, is your nocturia.
Okay. Getting up at night.
And that's one that
When you say it's the last symptom to get better, so how long am I waiting for it to get better?
I mean, that could be not only several weeks to, several months to totally improve. I mean, certainly we see that if
Okay.
you've been getting up 3, 4 times a night, that's going to go down to like, 2 to 3 times a night pretty quickly. But that last little bit, again, I think it speaks to its multifactorial nature.
You can do some procedures where it's safe if you're on active surveillance for prostate cancer. I mean, I talked to some folks who essentially they're active surveillance, they have low volume disease, and then they go ahead and they get treatment for their BPH. Where are we with, I'm on active surveillance, but I've also got this bad BPH issue. Can men with prostate cancer get aquablation?
So yes, with a caveat that Medicare currently has not released they haven't lifted their exclusion on that, meaning that it's been shown to be safe. It was only initially excluded because initial trials, which are normal for all BPH trials, did not include men with prostate cancer. But since then, it has been done on many, many patients with low as well as even high risk prostate cancer. It's been shown that it doesn't
High risk too?
even higher before they would get like radiation,
Right,
etc.
right.
It does not increase circulating tumor prostate cells after aquablation, and is generally considered to be safe. And actually, again, because of the easy recovery, a lot of clinicians offer it because they can if they're going to, undergo radiation, start radiation sooner than if they had a whole up or other type of procedure. It is so effective, and again, it's so precise in the design of where you resect that there are currently 2 trials to actually treat prostate cancer that are ongoing right now with aquablation as a form of kind of almost like a focal therapy, although it's being referred to as a subtotal prostatectomy, because not only are you getting rid of the area of prostate cancer you can see on an MRI, but you can also then get rid of a lot of the other tissues. And again, you can do this in a way that doesn't increase side effects. Because unlike a lot of the other focal therapies, the more prostate tissue you treat, the higher likelihood of a side effect. This actually is being studied, but it theoretically should not increase your risk of side effects.
So some men with prostate cancer, some types of prostate cancer can go on to receive this BPH treatment.
Correct.
How
As
about
a form
if
of
they,
treatment for not only their BPH, but also for their prostate cancer. Now, this is not every man, so
no,
don't
I
walk
just,
away with it, but there are certain populations that would be very amenable to this type of
and,
therapy.
and would you say primarily that's low volume active surveillance patients that would be good candidates if they wanted to check it out?
I think it is men with either a grade group 2, so a Gleason 3+4, favorable
Yeah.
intermediate risk, some higher volume 3+3, but in general areas that you can visualize on an MRI, that you can definitely go and target those type of areas.
Okay, then, oh, sorry, go ahead.
I was going to say it can also be used for the general patient with on active surveillance. And the thought there, and again, this may be the subject of a future study, there is to say, can you alter the natural history of active surveillance of saying that, hey, we know we're ultimately going to treat 30 to 60% of men on active surveillance. If we do aquablation, getting rid of that kind of excess at-risk type tissue,
Yeah.
can we actually keep you on active surveillance longer?
Interesting. But what about if the prostates are ready to receive energy? What about if it's been hit with a certain type of energy, being radiation already, or HIFU, or cryo? What about those guys who already received some type of treatment to the prostate?
So for most of those, it is considered safe. I know that certainly we have looked post radiation and used it. It's done really well. I personally haven't done post cryo or HIFU. I don't see why that would be contraindicated. The only thing that we haven't done is post brachytherapy because I don't know
Okay.
how we would respond. And most of those I don't think have really large prostates.
Yeah, it's already shrunk down. But you're not, but the hardening of the tissue, the fibrosis that occurs with some of these energies, that it's not
Cuts
an
actually better. It cuts the
issue.
water jet
What?
actually goes through those tissues even like it's really
Come
cool.
on, man. I did not expect that answer.
I'm sorry. That's just it's
That's interesting. People don't write about that enough. But what about the other way around? What vice versa? What about if you've got aquablation and then your PSA is really low, it goes up, and there's clearly cancer there? I mean, is there any?
easier to detect because you're getting rid of a lot of the BPH
Yeah,
noise. So we
exactly.
continue to screen afterwards. Two is that is the other beauty of aquablation. It does not preclude any therapy. I've done radical surgery after aquablation. The surgical plane's preserved. Very different than if you've had a whole lap or other laser procedure, or even sometimes TURP. Nerve sparing in those patients, still very easy to do. Um, you want radiation? I mean, we haven't limited you. That's the beauty.
What about if someone wants to get a retreatment? Can a second aquablation procedure be performed in one that's already been performed if the tissue grows? Because I'll tell you, I always try to look for what the catch is. We've covered most of them. Another catch I saw from some speakers at urology meetings was, yeah, they blow out all this tissue, but then 5, 10 years from now, that tissue can regrow in bad places.
We don't know. Certainly anecdotally, because of the initial trial, and again, this is way more information. I have done aquablation, a repeat aquablation on a patient,
Yeah.
and the patient only wanted another aquablation. And I will say is that is totally successful, and you can plan, and again, you can plan to meet any size or shape, even if it's asymmetric, etc. It works totally. And there are
Okay.
really cool ways that you can plan out your thing in that asymmetric prostate if they have that regrowth. So I don't think that it's contraindicated or should be. But from a practical standpoint, again, it all comes down to Medicare right now that they have it so it's limited to one aquablation procedure in your lifetime, just like a TURP.
So what a lot of people say about some other procedures like hole up is they'll say, well, you destroy that tissue, then it comes out and you can test it for cancer. But I never see anybody write anything good or bad about aquablation. I'm getting rid of all this tissue. Can I test
You
that tissue for cancer?
you do get tissue out because again, the most modern way that you do it is that you do the aquablation, you always look back in and you do what's called focal bladder neck cautery, meaning that you kind of get rid of a lot of the slough tissue, this kind of treated tissue,
Yeah.
uh, and that can be sent off. In our series, about 1.7%, and this is a very screened population, will be found to have prostate cancer incidentally. So it's a low incidental risk, but this is a highly screened population beforehand. If we know you have prostate cancer and you were on active surveillance, about 30% of those patients you can find cancer in their specimens.
I've seen a lot of aquablation videos and papers, and I don't see them going very far with the answers. Come on, I'm not that smart.
We collect all of these things. In general, it's the amount of tissue you send off is about 5 to 7% of the total prostate volume. So it's pretty low amount of tissue
Oh, so
coming.
it's low. So that's the catch. So the catch is all this tissue comes out, right?
Correct. And then you
And
send
you
it
can
off.
test some of it, but you can't test a lot of it.
Right. I mean, it depends. Again, you're still going to screen these. You're not missing anything.
Right.
This is still a screen population. I'm not worried we're going to miss aggressive cancers. Even whole up studies, about 4% incidental, 3+4 type of cancer. It's rare. I don't feel we collect it not because I'm an oncologist by nature, and so I always want to test everything, but I'm not really worried about these men in cancer.
But the average person who gets aquablation, that the tissue comes out, it's your prerogative, isn't it? Can't they test some of the tissue?
Yeah, you can 100% you should test that tissue if you take it out. I mean,
Okay.
we test everyone. We
Why
test
doesn't
everyone.
it say that on some of the sites?
I gotta put it in. I mean, this is what
I'm not
we've.
saying it's your fault. I'm saying,
No, it's
these
my
are the
fault
kind
actually.
of
We have the
questions that
largest
people
area.
watching PCRI have to know. It's like, I want to know if they can test that. I want to know if I have already been treated, if I can get this. I want to know if I get this and then I get cancer, what happens, good or bad. So I think you answered it. And it's a good thing I stick to time. I think I went only about an hour and a half over. I
I
completely took advantage
know.
of.
Well, listen, I don't have to answer to your wife. It's just tell her I say happy birthday.
Thank you. I will. My wife is very gentle. It's not a big deal. We're gonna have a good time. She's gonna be happy that I'm done with my interviews, and so. But I appreciate that. Feel free to send her an expensive gift.
I should. I should. Yeah.
Speaking of gifts, that's a great segue to end this tonight. This is a random thing. It's not a football. I'm not going to give you this gift. We got you another cup. Can we show you? Can you, Peter, can you bring up that cup? There it is, an Aquaman cup.
Oh, that is actually amazing.
Really?
Oh, oh my God, yeah. Do you understand how many people are going to be jealous of that?
I'm sure many, because it's a gift from us, including me, and people are just jealous of if
No,
you
it
know.
is great. That is fantastic.
We couldn't find an Aquablation cup, so we thought the closest thing was Aquaman. And so if you're a man doing Aquablation, theoretically you are an Aquaman.
It is fantastic.
We go to no limit. There's no limit here. We miss mortgages. We give life-altering gifts. Nobody will ever give you such an amazing gift. With that, a big hug to you, man. You just completed 2 different talks with us in less than a year, and you were a good person about it. We definitely covered a lot. And for a reminder for the audience, all these other treatments for BPH, we will cover it. It's not just in Dr. Helfand's talk. We will continue to cover it so that you can pick the best procedure for you if you need it. Anything else I can add besides the fact that you're a huge Michigan fan?
No, I'm just excited and I appreciate the invitation because I truly enjoy this. So
Good. I really do too, Brian. I've really enjoyed our 2 talks together. I hope we'll do something else in the future. I still feel more comfortable the fact that you've done 500 aquablations versus the person doing 15. I'm never letting that go. You can never take that away. So anyway, awesome job. For those people who are watching, go watch that first half of his talk when he covers all the other types. I could have not have done that better. It was beautiful. It was objective. Thanks for being here, man. Have a great, great year. I'm so happy you've been a part of this.
and thank you for the invitation again, and certainly we'll be in touch.
Great. Thank you.